Okay, I'll call.
Yeah, Vidya, please.
Yes. Good afternoon, everyone. And this is day 2 of our nutrition certificate course of ICOG. And I see dedicated delegates who have joined in again. I welcome our ICOG dynamic chairperson, Dr. Lakshmi Srikhande. We know her all for her dynamism and so many credits to her and so many feathers in her cap. So I welcome Dr. Lakshmi to say a few words about yesterday and today's program.
Thank you. Thank you so much, Vidya. And I take this opportunity to welcome all the dear delegates for our day 2 of 3-day online course on nutrition in women. And on behalf of ICOG, I extend my gratitude to Dr. Vidya Tobi, who is the convener for this course, who has crafted this 3-day module to cover each and every aspect of nutrition in women, more particularly related to our OBGY practice. Yesterday, Dr. Ranjana Khanna did a great job as a co-convener, and today co-convener is Dr. Kiran Pandey. Kiran, I welcome you, and I'm sure Kiran will also do a great job. So friends, I will hand over back to Vidya for the preamble of day 1. Then we will be having the pre-test, and after pre-test, we will be starting with our module, that is the scientific session. So back to Vidya.
Yes, thank you, Dr. Lakshmi. Yesterday was a fabulous day, and we had all eminent speakers who talked about nutrition and think nutrition first, that is an opportunity for action. So Dr. Sanjay Gupta elaborated about the epigenetics of nutrition. We learned about nutrigenomics, which is a study of effect of naturally occurring substances in the food on molecular expression of genetic material in each individual. And the second part, that is nutrigenetics, which aims to understand how the genetic makeup of an individual coordinates the response to diet. What is the aim? Aim is to obtain a better understanding of nutrient-gene interactions, which depends on the genotype. Nutrigenomics is a science that helps us to understand why some people respond to differently to same foods, beverages, and supplements they consume based on their genetics. So we can make definitely use of this information to develop a personalized nutritional recommendations. So nutrition can make a tremendous difference in gene expression, which in turn not only affects our health, but also that the generations to come. So DNA-based dietary advice results in a greater understanding of recommendations, greater interest in updating one's knowledge, and stronger motivation to change one's eating habits. So this should make a study of nutrigenomics and nutrigenetics. It is really exciting for us obstetricians dealing with mother and the child, because we are in unique position to improve both gestational and post-gestational outcome. Then we had a very nice talk by Dr. Ameya Purandare that was on probiotics and prebiotics and its relevance on gut flora. Healthy adolescent is an asset to a nation. Dr. Suchitra Pandit was the next speaker, and she told about the collective responsibility of the nation, schools, colleges, and parents to properly nourish and nurture adolescents with adequate vitamins, minerals to help them grow into healthy adults. So educating and ensuring adolescents take variety of food from each food group along with the physical activity will go a long way to bringing up the healthy adults. That's what we learned from her talk. And next was the preconception, pregnancy, and lactation. These were the topics, how the nutrient helps us. So pre-pregnancy, pregnancy, and postpartum nutrition is very critical for women and children's well-being, which also helps us to understand what are the critical interventions we can do. So poor nutritional status of mother before and during pregnancy, which extends throughout the life course, and definitely it affects the next generation. It leads to intergenerational vicious cycle of undernutrition. So pregnant women should be screened this is very important for the general practitioners, OBGYNs, and everyone, that one has to identify every woman nutritionally at risk, whether she's underweight, overweight, or obese, and should be counseled appropriately for the dietary management. And availability of the adequate amount of nutrients just before conception or during early pregnancy is very vital. So pregnant women are encouraged to consume balanced diet and should be ensured the adequacy of micronutrients, which is essential for minimizing pregnancy complication. However, one should also be aware of maximum level of micronutrient intake and the possible adverse effects in order to optimize the care of pregnant women. So preconception nutritional interventions are targeted to a woman of childbearing age in the period just before, at least 2 years, they say, and between the consecutive pregnancies. And availability of adequate amount of nutrient just before conception or during early pregnancy, that is less than 12 weeks of gestation, may influence critical processes of fetal developments. So these were the delivered talk by Dr. Jayam, Dr. Charmila yesterday. And about the micronutrients, deficiency of micronutrients are major global health problem. And micronutrients, they play a very central role in metabolism and maintenance of tissue function. And since our body needs micronutrients in specified amounts, deficit and surpluses of any nutrients can cause negative issues. So single micronutrient deficiency can be easily recognized, but there are certain issues like subclinical or multiple micronutrient deficiency is more difficult to recognize. So diet-related deficiency do occur. We know that in vegans, especially the elderly and various, if they of course, women are not, many of our Indian women are not alcoholics, but they also have certain deficiencies. So an adequate diet is very, very necessary, but excess supplements are also very much harmful. So micronutrients and trace elements have an important influence on health of both mother and fetus. So these are the things we have learned yesterday. And deficiency of micronutrients during pregnancy may give rise to complications. We all know that micronutrient deficiency cause anemia and hypertension, as well as impairing fetal function and development and growth. A recent meta-analysis, just I went through various meta-analysis, and they were evaluating the effect of antenatal multi-micronutrient supplementation in pregnancy outcome, and it has revealed a significant reduced risk of low birth weight and improved birth weight comparison with iron folic acid supplementation only and with multiple micronutrients. So there are various studies which have carried out. Then there was an important talk by Dr. Manjupuri. She talked of vitamin B12 deficiency in India. So it is very rampant. I was really, she has done many studies of vitamin B12 and multiple micronutrient deficiencies, and in India and especially in Delhi, she has published some paper also. And we learned many more things about vitamin B12 deficiency. So there are incidences that vitamin B12 deficiencies are associated with other adverse pregnancy outcome. Of course, the complications also they have noticed in newborns. So just look at pallor, knuckle hyperpigmentation, fall in the hemoglobin in spite of iron folic acid supplementation. Just do the peripheral smear and you will find MCV more than 100 macrocytes and dimorphic picture on peripheral smear, and you should suspect, and that suspicion should be of B12 deficiency. So just 1 or 2 injections of 1000 microgram intramuscularly of B12 they have given, and that have sufficed to tide over pregnancy in women with nutritional deficiency. So nutritional deficiency is not only about iron deficiency, but other micronutrient deficiencies also should come in your mind. So these were the topics which were covered. So it is high time we should think beyond iron deficiency anemia, and we should focus on micronutrient deficiencies as well. So there is always a task of clinician to impart the knowledge, to improve the local whatever the diets are available. You have to choose and teach our women. You should do counseling, nutritional counseling, and also you have to impart the see about the diet diversity, locally available diet. Counseling is very important part about the nutrition, recall diet. So it consumes a lot of time and we need to have the knowledge. So today we have day 2. We have got so many eminent speakers lined up, and they will be teaching us about the nutrition in high risk pregnancies. So I welcome them all and I hand over the proceedings to Dr. Kiran Pandey. So welcome, Dr. Kiran Pandey.
Thank you.
Yeah.
Thank you, Dr. Vidya. Am I audible?
Yes.
Yes, you are audible, and I'm seeing. Yes. Yeah.
So at the outset, I'm very thankful to Dr. Lakshmi for giving me this, and Dr. Vidya for giving me this opportunity of being a co-convener for a very prestigious course. And as you know already, it is the second day of the certificate course on nutrition. And Dr. Vidya has very nicely elaborated it nicely and crisply elaborated all the important points which were discussed yesterday. And today we are going to have the 2 sessions, and in which the different tasks are going to be like nutrition and hypertension disorders in pregnancy, nutrition therapy in GDM, food safety, know your packed food, nutrition and fetal growth restriction, PCOS, obesity and nutrition, nutrition in immunocompromised women, fasting and its effects, and calcium, vitamin D, osteoporosis. These talks will be discussed. And now I would like to invite our start.
Pre-test. Kiran, we have to take pre-test.
Okay, before, yes.
Jignesh, dear delegates, we will be sharing the link in the chat box. So Jignesh, please share the link, and you have to just open your chat box and start answering. Time given to you is 10 minutes.
Yeah, he has already shared the link.
It has already been posted in the chat box. Jignesh, please start the timer as well. Yeah. So we will be maintaining silence when you are giving pre-test.
Dr. Kiran, I have finally joined.
Welcome, Girija.
Welcome, Girija. Just 8 minutes more and we will be starting with your talk.
Okay.
विघ्नेश एक बार लिंक फिर से पोस्ट कर दे। हाँ So time up. Vidya, let's start with the session. Jignesh, stop the link. Yeah.
Yeah. Dr. Kiran?
Unmute. Kiran.
Yeah. Unmute Kiran and please introduce Dr. Girija Wagh.
Yes, thank you, Dr. Vidya. So I hope everybody has completed the P-test course, and now it's my privilege to introduce Dr. Girija Wagh for the first session. Dr. Girija is professor and HOD in the Department of OBGY, Bharati Vidyapeeth Medical College Hospital. She's a senior consultant, Cloud 9, Apollo Hospital, Pune, faculty professor, OGESH International Expert General Coordinator. She's chairman, Medical Disorders in Pregnancy Committee. She has been vice president.
I think we can share my CV on the group. Let's finish the talk.
Okay, actually,
Yeah, please, please, Girija.
Dr. Girija, you are such an eminent learner person that we wanted to talk about it, but as you wish. CV has not been able to, but the students have now must have understood that she's a very eminent teacher and she's professor and head of the department. So let's start, Dr. Girija, her talk.
Thank you so much, Madam Kiran, and above all, Dr. Vidya and Dr. Lakshmi for giving this wonderful opportunity and actually including this very important topic. And as Madam Kiran was introducing my CV, I would rather like to tell my CV in another simple word is something that I feel that I have dedicated my 30 years of experience and practice to preeclampsia in a big way. And one of the important interventions which I realize would really make a difference, even if the evidence doesn't exist for it, is nutritional modifications and trying to optimize health through this. And I want to thank Dr. Vidya through this passion of mine, because she gave me immense opportunities to speak about this, to talk about it and to reveal, and that gave me also another impetus to look after this particular aspect of nutrition, how it can modify hypertensive disorders of pregnancy. This is me, and thank you, madam, for introducing me so kindly. Now, in the next 20 minutes, we'll try to quickly deal with a lot of things. I can speak for days together, but we have to wind up so that you get a gist. HDP is a conglomerate of pathological conditions we know, and they usually, when they get presented to us, a lot of things are hidden behind. And what can really be prevent, apart from so many other things, is proper nutritional approach, which can be an important preventing and modifying intervention. Now, we are very well versed with the endothelial disruption occurring due to hypoxia, which is responsible for the entire rigmarole of hypoxic placenta, giving rise to release of various kinds of cytokines, and finally causing disruptions multisystemically as a pathogenesis or characteristic of this particular disorder. Genetic factors, the morbidities, environmental factors, and so many others have been identified to be the reason behind this. There is an abnormal immunological modification or adaptation, and all these factors seem to be modifiable by thinking of nutrition in the right way. Because if you look at the processes carefully and closely, you'll realize that inflammatory process and oxidative stress seem to be the basic pathologies which are occurring as the background of these disorders. And these inflammatory processes are responsible to give rise to so many issues that are there in the maternal circulation, in the placenta, as well as the fetal circulation. And the oxidative stress expressed as an inflammatory response is a result of these various factors. And what do you see? That nutrition, if you really ensure that the woman takes good quality carbohydrates, because we need a good energy source during pregnancy. And if you go and analyze women's diet who are especially getting admitted for preeclampsia, you realize that there is a deficiency not only in calories, there is deficiency in good quality fats, and definitely protein malnutrition is seen. Because intracellular lipid accumulation inside the liver, many times women, if you do a sonography, you will find that they have a NASH, that is non-alcoholic steatotic hepatitis, where there is intracellular lipid accumulation because of dyslipidemia, which can incite the inflammatory response, which can be further aggravated by the estrogen stress. Adipose tissues are also contributing to the inflammatory response by dysregulation in the secretion of adipokines and decrease antioxidant enzymes, and decrease insulin gene activity, decrease expression of mRNA, inflammation, apoptosis can be seen in the pancreas. Skeletal muscle will have similar kind of abnormalities associated with mitochondrial dysfunction. And all of these oxidative stress will finally result, and especially in the Asian ethnicity that we have, into insulin resistance, where obese, lean, and every kind of phenotype would have this kind of a malady. So if you look at the pathophysiology of preeclampsia gestosis, mechanisms vastly are influenced by maternal medical and nutritional practices and status. And we all know that abnormal earlier embryogenesis and shallow trophoblastic invasion is responsible for this entire pathway. And what are those environmental chemicals or nutritional factors which can make a difference? Omega-3 fatty acids, vitamins, trace elements such as calcium, and especially the lifestyle in general with physical activity would definitely make a difference. So factors which are responsible for occurrence of preeclampsia are excessive processed caloric consumption, excessive trans fats in the diet, iron deficiency anemia, as well as megaloblastic anemia and low ferritin levels, protein energy malnutrition, vitamin D and calcium deficiency, deficient micronutrients such as folates, biotin, pyridoxine, vitamin B6, and lower roughage and greens intake. And several studies have drawn attention to these associations between nutrition and preeclampsia. Macronutrients are very important, especially proteins are referred to as the building blocks of the body and are much needed during pregnancy to take care of increased tissue formation of the fetus placenta and the wear and the tear that the mother's body undergoes because of pregnancy dynamics. Now let's look at an example of a patient who was on the day 2 of her delivery. So this is a picture after 2 days of delivery, and she shows excessive edema, a sign of severe energy malnutrition and micronutrient deficiency. She has ascites, pallor, facial and upper arm edema, and something like as if she's drowning in her own waters. She's actually just a primipara, 21 years of age, delivered at 26 weeks with severe preeclampsia. So this is a condition where women embark on pregnancy with a setting of protein deficient diets. In consequence, it's like a kwashiorkor-like situation, further aggravated by pregnancy and its demands. And therefore, this realization and understanding will definitely help in modifying these conditions. So usually, I always like to speak to my patients, and this is something that you can also practice in your practices, is the protein theory, which I always like to speak about. Now, what is this protein theory? During pregnancy, the mom's blood volume increases by 50 to 60%, and her liver makes albumin from the protein she eats. Now, albumin is similar to egg white and pulls the fluid out of her tissues to help maintain the blood volume. If the mother doesn't eat enough calories, her protein gets burnt up for calories as opposed to being used to make albumin, and this causes a drop in the blood volume. The kidneys, thinking that there is drop in the blood volume, it may consider that maybe due to hemorrhage, produces an enzyme we all know as renin to make the blood vessels constrict. This results in high blood pressure, and the mother, thinking salt is bad for high blood pressure, starts restricting her salt intake. The kidneys try to reabsorb as much fluid and salt as possible to increase the blood volume. But because there is a lack of albumin and salt, the reabsorbed fluid leaks into the tissues, causing edema, rapid weight gain, and further increase in her blood pressure. So thus, we find women presenting with preeclampsia. So if we want to reduce the risk of preeclampsia, it is recommended that pregnant mothers consume at least 80 to 120 grams of protein daily and use salt to taste and do not go on salt-restricted diet. And I hope this is a convincing pathogenesis that I have presented here. Now, green leafy and cruciferous vegetables, winter vegetables, sea vegetables, culinary herbs, electrolyte-rich fruits, nuts, seeds, legumes, pasture-raised dairy and organ meat, fish and seafood, and sprouted whole grains are usually foods which are ideally recommended in preeclampsia. Now let's come to the micronutrient deficiency. Dietary factors influencing homocysteine metabolism and DNA methylation have been identified, and our group at Bharati Vidyapeeth and Irsha has done a lot of study on this and published. Now, folate, vitamin B6, vitamin B12, choline, and methionine from dietary protein all interact to maintain appropriate levels of homocysteine and regulate DNA methylation. And these epigenetic processes, including such DNA methylation, modify phenotypic outcomes with long-term effects on health and disease. And you can see here that these are folate cycles, choline, which is extremely important when there is coming from the dietary protein, DNA methylation, which can not only cause problems now, but has a capacity of transgenerational effect of these disorders, and hyperhomocysteinemia, typically as a result of B6, B12, and biotin deficiency, can give rise to cardiovascular effects and pregnancy complications. So when we look at the conglomerate of the pathogenesis of preeclampsia, the active form of vitamin D, 125 vitamin D3, has been demonstrated to adjust and function of the genes associated with normal implantation, placental invasion, and angiogenesis. So therefore, vitamin D deficiency can also be the reason. The immunomodulatory properties of 125 dihydroxyvitamin D are relevant, and abnormal implantation is proposed to be mediated at least in part by an abnormal immune response between pregnant mother and infant. Maternal vitamin D deficiency may increase the inflammatory reaction, and vitamin D deficiency may also increase the possibility of hypertension. Now, this has been our publication of maternal vitamin D deficiency influencing the long-chain polyunsaturated fatty acids and pregnancy outcome in association with alterations in 1-carbon metabolism. And this study demonstrated a possible mechanism through which vitamin D deficiency can result in an imbalance of the LC-PUFA metabolites and contribute to placental inflammation and endothelial dysfunction of eclampsia. Altered metabolic homeostasis between vitamin D and LC-PUFA have also been influenced and found, which would trigger inflammation through oxidative stress in preeclampsia, and this may lead to altered fetoplacental growth and development of preeclampsia. So maternal nutritional status, either poor, excessive, or disbalanced, can give rise to complications such as preeclampsia and hypertension, and toxic substances such as tobacco, alcohol, and pollutants contributed further. And remember, friends, that many women in India may not smoke, but a whole lot of them would be using smokeless tobacco, which also we must identify. And then there is an altered enzymatic placental barrier, LBWs, and the various consequences as a result of oxidative stress. Now, as I mentioned, micronutrient deficiency leading to FGR and consequent modification in the phenotype of the baby can program the baby for future metabolic diseases in the adult life. So whenever an index mother is coming to us, it is our bound responsibility to ensure that she is having proper nutritional guidance and she is also able to impart proper influences on the baby in utero. So rather than doing all the mantras and everything as Garbha Sanskar, eating good food can be one of the most important components of Garbha Sanskar, as we say, because restricted fetal growth and development, you can see that hormonal adaptations are dependent on iron, zinc, and calcium, and epigenetic gene regulation is dependent on folate and vitamin B12. And all these functions, the renal function, the cardiovascular function, the pancreatic beta cell function, body composition, and pulmonary function, all are influenced by the absence or the presence of these micronutrients. And this awareness amongst us all is extremely mandatory. So the dietary advice and management of outline of toxemia and pregnancy can be simple. There have been DASH diets which have been recommended in chronic hypertension, where dietary approaches to stop hypertension is their long form, rich in whole grains, fruits, vegetables, low in red processed meat, sweets, and sugar-sweetened beverages, and natural sugars like fresh and dried fruits are recommended. And you can do this in your practice on a day-to-day basis by creating your own diet recall. It's always better to identify the woman's 24-hour food frequency, or how I practice is 72 hours food frequency on a weekend. And so by time-wise, you make them write what they're doing. In my personal clinic, I'm sorry, I didn't add that form here. You can add a physical activity level also on the right side so that you know exactly what this woman is having. And it's always a good practice to give her a structured diet plan, which will be all inclusive, because the moment they become pregnant, the first question they ask you, doctor, main kya khau? So the answer to that is you eat good food, and it's always better to give them a proper lining. Now, I just want to know in the chat box, any one of you can put it up here and tell me how many of you have accessed the dietary guidelines for Indians, a manual which had come in the centenary celebration of ICMR. Has anybody accessed this? Please put yes, no in the chat box, or put your thumbs up in the chat box. So we would want to know, Dr. Vidya and Dr. Lakshmi will come to know that this is a very, very important. Thank you for those people who are being frank and saying no. So friends, I would recommend to our course runners to give this particular link. It is there on the Google site. Just go and access. This is a diet recommendation which our government has made, especially for all of us. And that can be your mantra to guide you about various things. Some experts, excerpts I have taken from this, like nutrients, food groups, and nutrients per 100 grams. And they have mentioned which are the right sources of energy, like rice, wheat, and tapioca. What are the right sources of protein? Many of us are taking a lot of vegetarian diet. So what is the right source of protein that I can have? And then based on the 100-gram proportion, you can make a diet yourself for your patient, or you can guide your patient based on this. So whenever we are looking at nutritional therapy in preeclampsia, we have to consider a lot of things where it can help. For example, folic acid will reduce homocysteine levels and protect the placental endothelium. Calcium, the government and the WHO recommends 1500 to 2000 milligrams of calcium per day taken during the entire pregnancy. And this will help in maintaining calcium homeostasis and control the arterial blood pressure. Vitamin D, absorption of calcium and reduced proliferation of vascular smooth muscle cells will be accomplished. Maintaining the redox hemostasis and immune responses can be brought about by zinc, magnesium, sodium, and other micronutrients. And probiotics are something which have come up new. These are dairy products containing L-rhamnosus, GG, acidophilus, and these are very important to maintain the internal manufacturing of the B12 and the B6 group. So this will all help in lowering the risk of hypertension during pregnancy. And this is that wonderful chart again. So whenever we go on the internet, we find the Mediterranean diet, we find so many other diets there. But this is a diet which has been made by our own ICMR for us. And this mentions that consume adequate energy and properly, eat moderately vegetables and fruits. Very, very sparingly, you must take things like beverages and extreme, processed non-vegetarians. And then these are the processed foods which should be taken less. So consume adequately, eat liberally, and eat moderately, and eat sparingly. So these are the various things. And of course, alcohol and tobacco should be. So this is exactly from that book which I have taken. So friends, Again, there it mentions about sources of iron. Many times our patients, we write on the paper, iron-rich diet. The moment we find a woman who is anemic, what should I eat is what the doctor says, what the patient says. So you can guide her. What are the sources of iron? What are the sources of calcium, fiber, folic acid? And these are the simple excerpts that I took, which you can refer to and guide your patient correctly so that your diet practices are given to the patient. Weight gain of the patient has to be extremely structured. And this knowledge you can give to her at the time of combined testing itself. So when she comes to you for combined testing at 12 weeks, analyze her pre-pregnancy weight, do her body mass index, and at the same time tell her that you have to have total body weight gain, which will be only determined by your pre-pregnancy weight. Because if there is excessive weight gain during pregnancy, because of usually improper diet, I normally tell my patients, if you eat well, your baby will grow. If you eat wrong, you will grow. So you have to guide them so that they do not land up in complications such as preeclampsia and diabetes. So pre-pregnancy body weight has been identified to be an important marker. So lose weight before pregnancy. So your planning of a pregnancy can be started beforehand. Many patients come to us for pre-pregnancy counseling. They have suffered a mishap in the previous pregnancy, or they are coming to you for fertility treatments. And then you can tell them, let's lose weight first. Early screening for glucose intolerance can be done. Behavioral interventions employing changes to diet and lifestyle. Cut down on fried, oily, spicy junk foods. Consume low glycemic index foods. Avoid refined foods. Consuming foods rich in N3, PUFA are important, and taking supplements such as folic acid and vitamin D can go a long way in optimizing health of women before conception. Now, this is very, very fresh from the oven, a guideline which was presented by Laura McGee et al. In the CHAP study write-up that they have recently written. And in that, it has been found that from the start of pregnancy, if the mother takes proper moderate exercise of more than 140 minutes per week, there can be 40% reduction in preeclampsia, apart from the low-dose aspirin that we are giving to the patient every time. And assess her dietary calcium intake, and if it is found to be less than 900 milligrams per day, initiate calcium supplementation by increasing it to more than 500 milligrams a day, will bring about 50% reduction in preeclampsia. And I think these are simple things that all of us can practice. Ask them to take best foods during pregnancy, such as whole grain 6 to 8 servings a day, then veggies 4 to 5 servings a day, proteins up to 6 servings a day, dairy 3 or more servings a day, and fruits such as 4 to 5 servings a day. Insist on taking high fiber vegetables and fruits, which will also give them antioxidants. And they have to keep on changing their millets all the time and the legumes, so that will help in improvising their gut health, so that probiotics and the assimilation processes in the gut will be improved. And then, as we have been speaking about the Gestosis score, which can be used as a simple clinical screening mechanism for all of us when our patients come. And all those women who are more than 3, of course, will get a vigilant surveillance. But even the ones who come less than 3, please ensure that you are giving them education about preeclampsia, talking to them about appropriate dietary supplements. They have to also be aware of excessive weight gain, should be given folic acid, calcium, vitamin, and DHA supplements have been identified to reduce preterm births. And then ensure that they are taking diet at the rate of 1 gram per kg body weight. So if this is practiced, I'm 100% sure just by our tender loving care during the antenatal period, you will be able to reduce much of the quantum of hypertensive disorders of pregnancy. So I think with this, I conclude my talk, and I hope, Madam Vidya, that I have done justice and have reached up to the expectations that you had from me.
Really wonderful talk as usual, and many take-home messages. At present, there are no questions in the chat box, but at the end of the 4 talks, maybe we will have some discussion on this. If you can remain back or you are there.
Yes, I'll be around. I'll be around. Hema madam, namaskar.
Hi, Girija. Namaste.
Namaste.
Welcome, Hema. Girija, fantastic talk. All
Very
the
well
passion was reflected in your talk.
Yes, yes.
I do it every day in every patient. So
That's why it is, I know that. So always whenever there is a talk on nutrition and hypertensive disorders of pregnancy, it is none other than Girija. As whenever there is a GDM and MN, there is Hema. So Kiran, over to you again to introduce our great speaker, Dr. Hema.
किरण पांडे को फिर से co-host बनाओ. हाँ.
उसको unmute नहीं हो रहा है.
She has logged in again ना.
Yeah.
The slide share should stop now.
Girija, Girija will have
Girija
to
will
stop,
stop the share. Girija, please stop your slide share.
Hema only share her screen. I'm sure first slide must be the CV slide. So Kiran can read from her mobile only. Hema, please share your screen.
Kiran, unmute yourself. So I think I will introduce Dr. Hema. All of us know Dr. Hema. She is a medical director at Divakar Specialty Hospital. At present, she is a DIPSI president. And we all know she was a past president of FOGSI. And Dean KCOG, we have our Karnataka College of ONG. And so many feathers in her cap, so many awards and recognitions. And her passion is on GDM. And she also chairs the FIGO PNCD committee, past ex-chair. And she has deliberations about so many deliberations on gestational diabetes. And we have heard so many times medical nutrition therapy in gestational diabetes, so many times. But every time I feel it is Hema only who can add on sugar in her speech. So over to him.
Add on, or she can deduct the sugar.
Absolutely. Thank you very much. Namaskar. I'm going to rename this series as Radiating a Wealth of Knowledge. Radiating because it is Kiran, the radiation, wealth, that is Lakshmi, and knowledge, that is Vidya. So this is a fantastic initiative because for a long time we've been, from innovation to implementation is what we say. So we've been innovating out of the box ideas, but actually it's gone to the implementation stage with Lakshmi at the helm of affairs at ICOG. Congratulations to you, first and foremost, and keep the great work going. Thank you so much. And today, we are all talking about nutrition, and FIGO says think nutrition first. And honestly, when Girija asked, how many of you really take the nutrition history? There were many, only 2 yeses and many no's. So that's a very honest feedback that really we need to rethink and think nutrition first, because as you have seen here, I will focus on the overnutrition part of it. As Vidya has just said, the overnutrition producing an increased chronic non-communicable disease, the tsunami of diabetes and hypertension, as the first 2 speakers, Girija and myself, are deliberating, and the triple burden of malnutrition, undernutrition, overnutrition, and micronutrient deficiency. And it reflects as metabolic syndrome right from the large birth weight baby to childhood obesity, and so on and so forth. So in a GDM patient, how do you counsel for nutrition? Well, many of our colleagues have said, we really don't pay any attention to the nutrition aspect unless we detect her sugars to be high. Because once the high sugars are there, then the mind starts ticking that, oh, we have to give her the medical nutrition therapy. And then we start thinking about what to tell, what not to tell. Until then, it's quite a clear blank about what really there is. Because nutrition prescription, we are not very prescriptive, or we are not saying it with conviction. but we need to understand more, not only with respect to GDM, but overall as how this course brings to you the entire spectrum around and about nutrition. So the type of food which matters, which gets right into your bloodstream 100% as blood sugar, is the carbohydrate group. So you need to really pay attention to the carbohydrates that you eat, because that will convert itself 100% within 15 minutes to half an hour. And it'll be a huge challenge to your body if the beta cells of your pancreas do not produce adequate insulin. When you take the protein group, it takes a longer time. 50% of it is converted into blood glucose, but over a period of around 3 to 5 hours. So your body has time to act upon that. If you take the fats, less than 10% of it is converted to glucose, and it's again over a prolonged period of time. So proteins are fine, little bit of fat is fine, but frank carbohydrates, it's a must, but the portion size, how much of what you will take, everything becomes very important when you are concerned about the blood glucose. Where do these carbs come from? These are the 4 groups that we've shown here. Starchy foods like bread, cereals, rice, which are the primary food substances in most of the Indian meals, whether it's rice or wheat. Unfortunately, both add a lot to the carbohydrates. Therefore, this year, 2023, being declared as the International Year of the Millets by our Prime Minister, whereas 2018 was declared as the National Year of Millets. Slowly, we are trying to change the thinking of every citizen in our country and around the world to shift from rice and wheat to jawar, bajra, ragi, and the millets group. So that's the focus that we are bringing around, because as you would see, all the starchy foodstuffs will directly shoot your sugars up. The beans, the vegetable containing starch like potatoes and corns, and of course, the sweetened fruit juices. When they say fruits, we must specify they must you eat the apple with the skin and not a formulated processed fruit juice with lots of sugar. So this is a different way of picturizing the same thing. In 2 hours time, carbohydrates will get right into your blood glucose. As blood glucose as the challenge to your body, proteins takes longer time, fats takes a long time. So every component of your meal at every 2 hours, whether it's breakfast, lunch, dinner, split all of these so that there is no overload of sugar. So that is the basic principle, and the main meal like a breakfast, lunch and dinner should get a larger amount of proteins than carbohydrates. This is the concept of food exchange. This is a very important and interesting concept because the carbohydrate counting is done in terms of exchange. And for every major meal, for breakfast or for lunch or for dinner, you are allowed only 4 carbohydrate exchanges. For example, if you eat 1 slice of bread, it is 1 exchange, that is, it gives you 15 grams of carbohydrate. If you eat 1 fruit, that is, again, apple with its skin, 15 grams, 1 glass of milk will give you 15 grams. So if you have to have 4 exchanges for your breakfast, 1 idli is 1 exchange, the second idli is 2nd exchange, the third idli is 3rd exchange. Half cup of sambar is a 4th exchange. You're allowed only 4 exchanges. So you can have 3 idlis and half cup of sambar, which is fine. Or cut down 1 idli, add 1 apple. Because why? Apple is also 1 exchange. 15 to 15, you're matching both. Okay. So this is the way you will calculate, and you'll have lots and lots of non-carbohydrate meals in addition. For example, the proteins in the form of eggs or 1 small pinch of fat, which will slowly rise your sugar, so it is not a threat. Again, how to increase the fiber and protein in the breakfast, which is very, very crucial. Low carbohydrates, high protein, and high fiber. That should be the rule of the game. So maximum number of vegetables and dals as shown in the first picture. And even if you're eating the same upma, you eat it of the upma made of broken wheat or coarse rava or the browns. And please, please remember, in the last plate, you have shown the portion size. You are eating something which is having a carbohydrate, but don't eat too much of that. For example, 4 rotis of carbohydrates. Instead of that, if you cut down to 2 rotis, that is, you're halving the carbohydrate, but add on a huge katori of dal or sambar and a huge chunk of sabji or vegetables, which will give you a mix of other kind of foodstuffs rather than the carbohydrates. So remember that the portion size should be very, very less, and the millets and the high fiber, broken wheat, etc., are preferable than the carbohydrates. Again, please, please pay attention to the numbers of rotis or dosas or idlis that you eat and the kind of food stuff that it's made. Multigrain atta is available, but unfortunately, many will take the wheat straight to the chakki and get the flour made. So they have no scope for fortification, no scope for multigrain. They'll eat wheat for wheat. So when we had the data from Dr. Vidya Tobi's place, which said we have only 4% of gestational diabetes mellitus, and we said your data must be all wrong. But knowing how good her postgraduates are, then we paid attention to how come in her public health institute, Alameen Medical College, the ratio is so low. Then we figured out that the bajra, which is the main type, the jawar roti, which is the main type, the peanut chutney, which is rich in proteins, all of these were the staple standard food of the women there. And therefore, they were already in their normal course eating the right kind of food, which were automatically a medical nutritional therapy for a large population. And therefore, eating right is the mantra. The diabetic roti, as we call, the soya flour, the besan flour, flaxseed powder, everything you add to the wheat, and then prepare the roti or the puri with that or pulka with that. This is a mix. That is why we said multigrain, which is always beneficial. And you may just say, oh, I'm just eating a Marie biscuit or two. But remember the exchange principle. When you say biscuits with as compared to the nuts, just 4 marigold biscuits will be straight away one exchange of the carbohydrate. So if you eat a whole pack of the biscuits in between, you're taking essentially a lot of carbohydrates. Whereas to match that same amount of carbohydrates, you have to eat 110 almonds. Okay, so which means if you eat 2 to 4 almonds, it will contain so little of carbohydrates and so much of proteins and fat that is the kind of picturization which you must have in your mind while even explaining to the patient. Always encourage them to buy a dry fruit dabba, and if they eat 2 cashews, 2 badams or akrut as an in-between meal, that will be a very, very safe thing to do. Whenever we detect hyperglycemia, the first round of therapy will be medical nutrition therapy, and we aim to have the fasting blood sugar or before meal at 95 mg%, 2 hours after meal at 120, and the HbA1c less than 6 grams. That is our aim. So what do we normally say? You test, and if it's more than 140, then you advise her the right kind of diet and call her back in 2 weeks' time, retest again, and if she's in the range, you continue the medical nutritional therapy. Most of the times we fail because we haven't managed to convince the patient what she should be eating and why she should be eating whatever she's eating. Even in pre-existing diabetes, we more or less maintain the same targets, because in pregnancy, it's very, very crucial not to have the chalta hai attitude because the baby is at stake. So if you have only 5 minutes and you have to make 5 points very, very clear to the patient, okay, reduce the grain size, no going beyond 2 numbers, either 2 idlis or 2 dosas or 2 rotis, no going beyond 1 cup of soup, whether bowl size or rice, upma, poha, etc. should be small. So pay attention to the portion size and frequency and time. 3 small meals, 5 in between snacks, and fixed time for all the meals. Why? Because you feed your body little by little, little sugar is getting into the blood, and the insulin present can easily manage that. So that is the philosophy or the principle of having many small meals through the day. The protein source can be paneer, soya, dals, lentils, sprouts, boiled groundnut, other kinds of nuts, seeds, egg, chicken, small fish, and milk. There's plenty of proteins available there. But again, a whole bowl of dals, etc., will give a rich source of protein rather than having a whole scoop of rice with just a little bit of dal. That's the reverse combination that you must do. No bakery items, no packaged foods, and the biscuits also, I've told you, it looks benign, but it's really rich in carbohydrates. If the small 5 times snacks is what we have told, so what does she have for those snacks? Either roasted chana or nuts or seeds or puffed rice with sprouts, cut fruits or salads, buttermilk, or any homemade traditional snacks, vegetables for fiber. You have to be practical to give her these kind of options, because just telling a diet chart which she cannot even relate to. So really, one has to take the dietary recall to just manipulate and modify, eat more of this and less of this, eat this many more times. That's how you have to circulate. Now, being the chair of the Well Women Committee of FIGO, and previously I was chairing the Pregnancy and NCD Committee, where there was a lot of focus and work that we did on obesity and nutrition in pregnancy. So what is FIGO doing about it? We've come up with a FIGO nutrition checklist, which is there up on the FIGO website. We have modified it to the Indian context as well. It has 4 simple columns. One is identify the specific dietary pattern of the women. Just as simple as whether she is vegetarian, vegetarian, or non-vegetarian. So that then onwards you can ask her the right kind of food stuff, what she must be eating. Secondly, take the height, weight, body mass index. In fact, after the first 6 years of running the Manyata program, in the antenatal checklist, in the care of the antenatal patient, we added the height, weight, and BMI, because somehow it had skipped our mind, because it's so crucial, so fundamental, but we did not include it then. But then think nutrition first. So this is the second part of the checklist, which is again simple to fill up. The third part is actually what is the group of food substance that she's eating, whether it's protein, carbohydrate, or fat. These subgroups with the types of food substances mentioned there, so that she can easily relate. Oh, she's eating a lot of rice, then it goes into the carbohydrate group. It is mentioned there. So she'll say, okay, I'm eating rice. I'm eating it 3 times a day, rice, and rice. So how many times she's eating, what portion is she's eating, how many times a week, and what is the kind of food substance. Like, for example, packaged snacks. Do you go to the bakery and eat a lot of pastries or packaged food? If she says yes every day, then it's a lot. And then the 4th section is micronutrient status. Is she already taking some supplements like iron, vitamin D, folic acid? So very simple checklist to fill in. So we wanted to train all our frontline healthcare providers and the clinicians to just use a checklist, and our article has been recently published in the CEFOG journal. It's all about implementing the FIGO checklist for pregnant women. What are our opportunities? What are the challenges in low middle income countries? It's a very well accepted article. And was the dietary history taken as a routine before we introduced the FIGO checklist? Most of them said no. We were taking it in any bizarre manner, sometimes mostly when we find the high sugars, but as a routine, certainly not. When we said introduce the FIGO checklist, just write vegetarian or non-vegetarian, just take the BMI, just see the food groups, and just see the supplements, then they said, with what ease you can use this FIGO checklist. 82% said it is really simple to use, and time taken to administer this checklist is less than 5 minutes in most cases. Maximum it's 5 to 10 minutes. This is all that you have to do, but you have to do it. Okay. Did you feel that the information gathered from here was useful to you to advise on certain deficiencies? And 90% overwhelming answer was yes. And the mantras like in the pregnancy to dispel the myths and misconceptions. Don't eat for two because you need to maintain your sugars. The weight gain, we have to keep checking and manipulating it to about 6 to 8 kilograms throughout pregnancy. Low carbs or the low glycemic index is to be focused upon. So the weight gain, you have to pay attention. Normal pregnancy 10 to 12 kilos, but in GDM patient, we have to restrict it to 6 to 8 kilos. Even if she loses a little weight, whole family is worried. You've got to counsel them that this is quite the right thing to do. And lastly, it has to be coupled with the exercise. We stratified the recommendations of FIGO depending on the resources available in various countries. But just look at this recommendation. When it is about the physical activity and upper body exercises, etc., there need not be any resources. Whether it's high income, middle income, or low income countries, everybody has to do this. You know, it's non-negotiable. Resource setting doesn't come into the picture. This has a very strong quality of evidence, and all should definitely follow this. And to end this in a manner, how an OBGYN will look at a case of hyperglycemia of pregnancy. Yes, we focus on the targets of the blood sugars. Yes, the large part underlying foundation is the medical nutrition therapy. So we got to remember to implement the FIGO nutrition checklist and guide in a very practical and pragmatic manner. But we have lots of other things to bother. The same patient may be anemic and undernourished as well. Some women get really frightened and start eating so less that it becomes a growth restricted baby. Anemia, we really require a lot of iron supplements. PIH, now Girija has told you what to eat, what not. And some subtle findings like polyhydramnios and all, you know that the sugars are not under control. Randomly, once you check, it may still be in the range, but the baby is getting influenced with that. We have other important issues to tackle as well as preterm labor, the delayed lung maturity, congenital malformations, time and mode and place of delivery. When we're overwhelmed with so much, then we say, Arey, Abhi, what? Nutrition, nutrition, nutrition. But nutrition is really important. Think nutrition first will still be our advice. That is why I have to once again doubly congratulate this team, because we started a program called ABC of Nutrition. A is ahead of pregnancy, B is be cautious during pregnancy, and C is continuum of care beyond pregnancy. And you know what? There were no takers for these webinars. Just the 2 webinars we did, and then, you know, everybody said, what? Nutrition, nutrition. And really, really grateful today, Lakshmi, ICOG, Kiran, Vidya, entire team for bringing this into the center stage, because all those who are taking this as a ICOG course are serious about this, and they will do their pre-test, post-test. Even if they learn 1 or 2 small little principles, it will really change the healthcare ecosystem, because the government is screaming on top of their head about Anemia Mukta Bharat, which is nutrition related, Poshan Yukta Bharat, again, which is nutrition related. And every attempt has been made by every other stakeholder about eating right. We did another paper which said we took the amount they're spending for eating. So it is in many, many metros, the money is not the concern. They're spending a lot, but they're not eating right. They're just really not eating the right kind of foodstuff. So the capacity building of our own colleagues and their entire teams of the staff, once again, I underscore and emphasize that this may look simple. This, you should not think it is somebody else's responsibility to do this. You have to own up to the fact of the limitations that you have had before. And now we have to wake up to the reality of doing better than what we were doing. With that, may I wish that you eat well, sleep well, and live well with a healthy life. Namaste. Thank you.
Thank you, Dr. Hema. It was a great talk, very practical and emphasizing the right points, how the healthcare providers have to be really engaged into it, not thinking that it is not our responsibility, it is somebody else's. and very, very small points and finer points you've told, that weight gain should not be in the first trimester. So one has to be very particular, because in our families, mostly the mother-in-laws have this tendency, the moment the bahu gets pregnant, we should eat a lot and should eat for two. So those myths you corrected very nicely.
So all these
Thank you
muh
very
meetha
much.
kijiye, muh meetha kijiye.
So it was a very practical type, and I'm sure our residents must, I mean the students, who have participated, the participant must have got benefited. Even Dr. Girija, I could not summarize because I was not able to unmute. It was a very eye-opener talk which you said, and so many things even I was feeling we don't know of the diet so finally, which you said into the pre-eclampsia, especially the salt restriction. That is a very wonderful strategy. So should I share and start with the next
Yeah.
talk?
Thank you so much.
I will share my
Thank
screen.
you.
Yeah, thank you, Girija. Thank you, Hema.
Thank you, Hema.
The
Thank
whole
you, Hema.
purpose of having this 3-day course is to spread awareness amongst our own OBGY colleagues about the importance of nutrition, as rightly pointed out by Hema and you. So,
At least that sensitization is there, that
Yes,
nutrition is
yes.
an integral part of their practice.
Yes.
and as Hema said, yes, I will also be happy if they can just learn 1 or 2 points and start incorporating that into their day-to-day practice. Because here we are teaching a lot, but they should imbibe it and start practicing in their day-to-day practice. So thank you once again. Yeah.
So may I have this privilege, a special privilege of introducing our own ICOG chairperson, Dr. Lakshmi. Once again, thank you for giving me this opportunity. And as we all know, she is chairperson of ICOG, Indian College of OBGY, national correspondent editor, Journal of OBGY of India, JOGI, which is the very prestigious journal, National Corresponding Secretary, Association of Medical Women India, founder, patron, president, ISUPA Vidarbh chapter, chairperson, IMS Education Committee, president, Association of Medical Women, Nagpur Ratan Award. She has received many other awards, Bharat Excellence Award, Meru Dara Hansotia Best Committee Award. She has been chairperson of HIV AIDS Committee, and she has received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child, which we all appreciate so much. She has been senior vice president, president Menopause Society, president Nagpur Society, and has delivered 11 orations, 450 guest lectures, publications, number of publications, both internationally and nationally. And she has been passion of sensitizing the boys and girls on the adolescent health issues. So young friends, you can understand now how learned and how passionate about the education is. And the most other important thing, she has started so many courses for your benefit. So please take advantage. Don't miss this opportunity of taking up these courses. Thank you, Dr. Lakshmi. So that platform is yours now.
Yeah. Thank you.
I'll stop sharing.
Yeah, I have already started sharing my
Yeah,
screen.
you do.
So thank you, Dr. Kiran. Thank you so much for your kind introduction. For the benefits of delegates, let me just tell them that make it a habit to visit our ICOG website, as all the web series which I have started are free of cost, and the calendar for April and May has already been uploaded on ICOG website. Because I have read many comments in the chat box that we came to know about this course today only. So please make it a habit. Go through our April and May calendar and just mark your dates, which of the courses or web series you want to attend. Now, after learning so much from Dr. Hema and Dr. Girija, they were all talking about the kitchen food. But friends, many of the pregnant women and also working women nowadays, they don't like to cook. Neither they get full-time maids who can cook for them. So what is the answer? They all are dependent on packed food. But let us have a look at this slide. when and how much Indians check nutritional information when buying packed food? Yes, of course, if you are looking for a certain type of food, 43% they go through the label. When I'm thinking of buying the product for the first time, so you are apprehensive, 42% go. When I am on a diet or trying to lose weight, then to only 22% they bother to read the label. When I have the time, but still if you are having the time, only 16% bother to read the label. Always only 14%, they are so meticulous that they read the label first before buying the food. When you are buying food for the children, again only 12% they bother to read the label, and 7% they never bother to read the food label. Why I showed this slide to you? Are you all aware about the labeling regulations in India? Every packet food has to be labeled in accordance to the packaging and labeling regulations as per the FSSAI 2011. That is Food Safety and Standards Authority of India. And what they are supposed to write on their label? They have to write the name, the net weight, net contents, the list of ingredients in order of weight in that package, addition of artificial color, flavor, preservatives, what is the percentage of daily value based on 200 calories a day, symbol of indicating whether it is veg or non-veg. Also, they have to write the port number, lot number, batch number, date of manufacturer, best before date, instructions for use, allergy information, and any health claims which they are making. So now let us go through this information one by one. Currently, most of the packaged food companies, they print nutrition details of the contents, including their recommended daily values at the back of the package. That was 2011. But in 2020, the change was introduced by FSSAI. And this legislation has mandated the packaged food companies to label high fat, sugar, and salt content in the front of the package itself. The food label will also declare per serve percentage contribution to RDA, that is recommended dietary allowance, on the front of the pack. So this was the change which was made in 2020. So what do I mean by that? That every food packet must carry a label on the front side of the packet which contains all these informations. Now, how to read food labels without being tricked? Because not everything which is mentioned on the food label is correct or accurate. Consumers are more health conscious than ever, so some food manufacturers, they use misleading tricks to convince people to buy highly processed and unhealthy products. Everyone should know how to read these food labels so that you can differentiate between mislabeled junk and truly healthy foods. So how to do this? First and foremost is you have to read the name of the product. You all will say, but we do read name of the name on the label. That is why we buy that packed food. But friends, it is not that easy. The name of the food must be clearly stated and it should not be unclear or confusing. If the food has been processed in any way, the process must be included in the title. That is, you have to read whether it is a dried apricots, salted peanuts, or smoked bacon. The name must also describe the differences between apparently similar products. That is why I was insisting on reading the name correctly. Whether you are buying a fruit yogurt, which differentiates it from artificial fruit flavoring yogurt. So be very careful when you are reading the name of the product which you want to buy. Now coming to the net quantity. All packaged food must carry the net quantity by weight or volume or number as the case may be. The net quantity of the commodity contained in the package must exclude the weight of the wrappers and the packaging materials. What is the first thing apart from the name which you should look at on the food label? When you are looking at the nutritional facts, first take a look at the number of servings in the package. That is serving per container. And the second important thing you all should note is the serving size. Nutrition labels, they state how many calories and nutrients are in a standard amount of the product. Often the suggested single serving. However, these serving sizes are frequently much smaller than what we consume in one sitting in our home. If you are interested in knowing the nutritional value of what you are eating, you need to multiply the serving given on the back of bag, the number of servings you consume. So friends, this is very, very important that you should know the number of servings in that pack and the serving size. What is the importance? Why I am insisting so much on this? Let us have a look at this example. 5 gram fat is equal to 1 teaspoon of fat. If a food says it has 30 gram fat per serving, that is equivalent to eating about 6 teaspoons of fat. The second example, 5 gram sugar is equal to 1 teaspoon of sugar. So if a can of soft drink has 40 gram sugar, that is like eating 8 teaspoons of sugar. So that is how you all should be able to correlate how much you are eating from that packed food. What we all need on the food label is, of course, the serving size that is in our household and metric measure, so that we are not tricked by it, and the servings per container. Always check the serving size first. All the information on the label is based on the serving size, and many packages, they contain more than one serving. The total carbs are listed in bold letters to stand out and are measured in grams. Sugar, starch, and dietary fiber, they make up total carbs on the label. Sugar is listed separately. All of these carbs except fiber can raise your blood sugar. So if you have diabetes and you are counting carbs to calculate your insulin doses, the American Diabetes Association recommends that you use the total carbs to calculate your insulin doses. Some people may get better results by subtracting some or all of the dietary fiber grams from the carb count. Dietary fiber is listed just below the total carbs. Buy foods with at least 3 to 4 grams of fiber per serving. Whole grain breads, fruits and vegetables and beans and legumes are high in fiber. Check the total fat in one serving. Pay special attention to the amount of saturated fat in that one serving. Choose fats that are low, choose foods that are low in saturated fat. For example, dried skim or 1% milk instead of 2% or whole milk. Skim milk has only a trace of saturated fat. Whole milk has 5 grams of this saturated fat per serving. If a food has less than 0.5 grams of saturated fat in the serving size on the label, the food maker can say it contains no saturated fat, and this is allowed as per the law. Remember this if you are eating more than one serving. You should also pay attention to trans fats on any food label, because these fats raises bad cholesterol and lowers your good cholesterol. These fats are mostly found in snack foods and desserts, and many fast food restaurants use trans fats for frying. If a food has these fats, the amount will be listed on the label under total fat. So you should make it a habit to read the fat content in detail. They are measured in grams. Look for foods that have no trans fats or are low in trans fats. That is, they are having 1 gram or less. Sodium again is the main ingredient. We all know the number is important for people who are trying to get less salt in their diet. If a label says that a food has 100 milligram of sodium, this means it has about 250 milligram of salt. So take note of this sentence, that 100 milligram of sodium in the food packet is equivalent to 250 milligram of salt consumption. You should eat no more than 2300 milligram of sodium per day. This is the amount of sodium that is in 1 measuring teaspoon of table salt. The percent daily value is included on the label as a guide, and the percentage for each item on the label is based on eating 2000 calories a day. Your goals will be different if you eat more or fewer calories a day, and a dietitian or your provider can help you set your own nutrition goals. Now you have to study the ingredient list, and product ingredients, remember, are listed by quantity from highest to lowest amount. This means that the first ingredient is what the manufacturer used the most of. A good rule of thumb is to scan the first 3 ingredients, as they make up the largest part of what you are eating. If the first ingredients include refined grains, a type of sugar, or hydrogenated oils, you can assume that this product is unhealthy. Instead, try choosing items that have whole foods listed as the first 3 ingredients. In addition, an ingredient list that is longer than 2 to 3 lines suggests that the product is highly processed. Friends, look at this slide very, very carefully, because this is how we all get tricked as far as the sugar content in that food label is concerned. We never realize that there are so many different names for sugar, and these names are used by these packaged food industries to trick the consumers. The types of sugar, just for example, you can read beet sugar, brown sugar, buttered sugar. The list is endless. The types of syrup which are high in calories and sugar are carob syrup, golden syrup. Other added sugars you should be able to read in the form of barley malt, molasses, cane juice crystals, lactose, corn sweetener. Again, the list is endless. Many more names for sugar exist, but these are most common. I want you all to know these uncommon names of sugar as well when you are buying any packed food. If you see any of these in the top spots on the ingredient list, or several kinds of these sugar names in the ingredient list, then the product is definitely very high in added sugar. Now, what about additives, colors, and flavors? Food additives contained in the food product must be mentioned along with the class titles, along with the specific names or recognized international numerical identifications. It should mention that this product contains permitted natural colors just beneath the list of ingredients on the label. In case of addition of extraneous flavoring agent, then it should be mentioned in a statement like it contains added flavor just beneath the list of ingredients on the label. Now, how to identify the natural and artificial flavors? I know we don't have time when we go to buy these foods, but friends, these are some of the list where you can have over 2000 chemicals are combined to make 500 natural flavors. So natural flavors are really not natural. Here, the chemicals are combined to make natural flavors. They are typically created and combined in labs. They are made from edible ingredients, and vague definition allows companies to take advantage of loopholes. Whereas artificial flavors are lab combined chemicals made from inedible ingredients. So whenever you are buying any packed food, you have to be able to differentiate between natural flavors and artificial flavors, as artificial flavors are very, very harmful, and it can contribute to a variety of health issues, including brain tumors, seizures, depression. So these are some examples of natural flavorants which you all can read.
Hi.
Now you have to read the names of the artificial coloring, flavoring and preservatives added during manufacturing of the product. And I know it is very difficult to understand the names like preservative 211, which is mentioned in Maggi tomato ketchup. This 211 means sodium benzoate. So you have to be very, very alert what you are buying. Foods that are known to cause allergy and intolerance, they may be listed in a box or highlighted to draw attention to their product. That is, this product contains milk and manufacturers will require packed foods to provide allergy information. Date, remember there are two different date marks which appear on food labels. First is use by. Use by is found on perishable foods like milk, meat, fish. That is, foods are not safe to eat after this date. The other date mark is best before. This is found on a wide range of food including fresh, frozen, dried, canned and other foods. Foods can be eaten after this date, but they may not be at their best quality. Now, veg, non-veg symbol, you all are familiar with. Name of the address, packer or seller has to be there on the label so that consumers can contact them if there is any complaint about that product. In case of imported food, the package must contain the name and complete address of the importer in India. Lot or batch number has to be there so that in case of any problem, the whole batch can be recalled by the manufacturer, packer or producer. Barcodes are not important to us, but they are important to the shopkeeper because barcodes are a quick and easy way of identifying items, especially at the supermarket. Now, preparation instructions should also be there on that food packet. Just for example, if the food has to be heated, the temperature of the oven and the cooking time has to be stated on the food label. Any special storage instructions or conditions of use, if that food packet requires, it has to be mentioned on that label. Now coming to this labeling of foods containing genetically modified content. On January 1, 2013, India joined a select band of countries where food containing genetically modified content must be labeled as such on the food label. So friends, after telling you so much about how to read labels, the next question which arises is, do nutrition labels lie? That is, if you have read the label carefully, are you all safe? No. Unfortunately, nutrition fact labels are not always factual. For starters, the law allows a pretty lax margin of error, that is up to 20% for the stated value versus actual value of nutrients. In reality, that means a 100-calorie pack could theoretically contain up to 120 calories and still it might not be violating the law. In April 2019, FSSAI introduced strict regulation against false claims and misleading information. For example, soup packages that mention being healthy or nutritious can't make this claim since they are high in sodium. So FSSAI is there, which is taking care of your health. You all are familiar with Nestle controversy. I'm not going into detail to this controversy. So what kinds of claims are legal to make on food packaging? There are three categories of claims which are defined by FDA regulations. That is health claim, nutrition claims, and functional claims. Health claims means any representation that states, suggests, or implies that a relationship exists between a food or a constituent of that food and health. Nutrition claims means any representation which states, suggests, or implies that a food has particular nutritional properties. And risk reduction is in the context of health claims, means significantly altering a risk factor for a disease or health related conditions. So do make a habit to read what kind of claim this food label is claiming. These are the common claim types we all come across because we all are so health conscious. So just take it a time and just go through all the claim types which are there on the food label. I would just like to add something on this slide, that don't assume that all foods displaying the word light are low in fat or calories. The term light or light on a food label may also mean the food is light in fat, light in salt, light in color, or even light in taste. The characteristics which makes the food light must be stated on the label. So take a closer look to see what this word light really means. Are there any exceptions to mandatory nutritional labeling? Yes, fresh fruits and vegetables, raw meat, poultry and fish, seafood, alcoholic beverages, and foods which are sold at roadside stalls. So friends, I really wish if the foods are really honestly labeled, you all can see these will be the labels, but unfortunately or fortunately, we don't have these kind of labels. But thanks to the food labeling regulations, consumers can now make a wise decision and choice before buying processed food products off the shelf and feel safe than sorry. So friends, thank you so much for your patient hearing, and do take time to read your label before you buy any kind of packed food.
Hello. Thank you so much, Dr. Lakshmi. You told so many things which I think none of us must have ever thought of. We always purchase. We do know that packed food is not good, the basic concept. But to go to such a great extent, read it, is really, I mean, we are not doing it. So, I mean, now you have opened our eyes. Next time when we purchase
there are so many
it.
comments in the chat box.
Definitely there must be. Is there any question also, Dr. Vidya?
No, all informative.
All informative, yes, yes.
And they're very scared to buy packed food now.
No, don't be scared, because now that is a reality. To be very frank with them, I mean, we all cannot cook daily, but just be careful, read the labels carefully and then buy.
Only don't go by the face of value of it.
Yes.
That somebody says it, it's not that. You have to go in detail. And I think, Dr. Lakshmi, one starts going after 2 or 3 times, as you said, that the first 3 content are the most important. Then one would be able to identify them. It's the only thing, we have to be cautious and we have to be particular.
If you
So very, very
read
informative.
those small letters, Kiran, just everyone is having a mobile and every mobile has got that magnifier in that. So please use that magnifier to read what is written on those labels instead of giving excuses that words are so small that I can't read.
Yes, and
So
you can take a
best use of
picture of
mobile.
it and then enlarge, zoom it.
Yes, best
That's
use
also
of mobile. Every mobile has magnifier.
Yes,
So
yes, you
read.
are right. You are right. We do give sometimes things. So this was really very informative, and you have done so much of research, I would say, on to the topic. And it's going to be wonderful, I mean, of use to everyone. So am I permitted to share the screen for the next speaker?
Yes, please.
Yeah, so there's a minor change into it. I'll just go and share. Yeah, so there's a little bit of change. I'll now Dr. Anju Soni will be delivering the talk, as Dr. Jayanti had to go somewhere. So welcome, Dr. Anju. You are here. Dr. Anju is here.
I saw her. She is logged in. Anju?
Are you ready,
Yeah.
Dr. Anju? Should I say?
Yeah, I'm ready. Yeah, I am there.
Okay,
I'm there.
Okay, so right. So welcome, Dr. Anju, and we all know She is at the present chairperson, HIV and AIDS Committee, FOGSI, and she's Secretary General elect.
This is my old CV. Can I start? my
That is what I
presentation?
was thinking. She's now elect president, actually.
I don't know. I shared
IMS.
my proper CV. Somebody put up the old one.
Okay, no problems. So many
in my presentation, there is a CV.
important. So she's you present there, but at the moment, let me just see. She has been past things. At least she has been president of JOGS. She has been president of Jaipur Menopause Society, committee chairperson, public awareness, vice president JOGS, secretary, patron, and
Thank you.
member of International Menopause Society also, and many awards, Dr. Anju. You are not giving me the chance to talk about them. But Chikitsa Vibhushan, IMS, Narchi, AWA, Beti, Shrishti Ratna Award. So welcome, Dr. Anju.
This is my 3 years old CV. I don't know from where.
So somehow it must have got no issue. It's fine. So you please
fine.
share your screen and go ahead with it.
You have to stop sharing, darling.
I will definitely. I'm just going to. Yeah.
Yeah. So thank you, Dr. Lakshmi, Dr. Vidya, Dr. Kiran, for organizing this beautiful webinar. We are talking very little about nutrition, but I am sure all of us, it's the primary need for today. You know, we have to talk of nutrition more. Are my slides seen?
Yes, ma'am.
They're seen.
1 second, just give me 1 second.
You have to make them full screen.
Yeah, I have.
Yeah.
So good afternoon, everyone. And it's my pleasure to be here for this ICOG course. I have been really thankful to all of you for inviting me for this prestigious, training course. And, I feel that nutrition is something very important, and it's so important that we must all have lots and lots of knowledge. And I'm going to talk about today nutrition for immunocompromised women, because we all of us come across this problem in day and night. So let me start my presentation. When we talk about this, we're going to talk about the historical background, relationship between immunocompromised and nutrition, effects on nutrition or resistance to infection, and effect of infection on nutrition status, and what is the mechanism of infection and nutrition, all these things. So when we talk of historical backgrounds, 1 second, just give me a second. There is serious patient admitted. I'll call you in half an hour's time. I'm busy. I'm giving a talk. I'll talk to you in 20 minutes, please. Okay. Yeah. So nobody talked about nutrition until 1950s. There was little or no mention, especially the relation of infection. But some articles started coming, for these patients of immunocompromised disease, and the studies in, of course, experimental animals and obesity were pointing out the role of infection and immunocompromism in precipitation of nutrition disorders. What more that, the clinicians and nutrition did not recognize the importance of relationship till much late. But in late 50s, the field and metabolic studies demonstrated there was a synergism in the humans, and effects were then extensively investigated, and lots of research went on. The experience and knowledge of cell-mediated immunity, we all know, led to understanding how malnutrition lowers the body's resistance, and the infection is there in leading cause of morbidity as well as mortality, not only in women but in children across the world. So malnutrition, we all know that it is immunocompromised complex remains the most prevalent problem globally. So before going to nutrition, we must understand what is our immune system. We are constantly exposed to potentially harmful materials, and our immune system is a network of intricate stages and pathways which protects us from these harmful organisms. Now, there are different types of immunity. Innate immunity is the first line defense from pathogens, and it enters our bodies and is achieved through protective barriers, which include skin that keeps out the majority of pathogens because that traps the pathogen, stomach acids that destroys the pathogen, and enzymes in our sweat and tears that help create antibacterial components. Then immune system is very, very important in these cells to take a large. Now, other type of immunity is adaptive or acquired immunity, and where the body learns to recognize a pathogen, regulated by cells and organs. It is organs like spleen, thymus, bone marrow, and lymph node, and they create antibodies, and that lead to multiplication of immune system and to the specific harmful substance, and then it forms a memory in the body. So whenever our body is exposed to that kind of pathogen, again, it comes and protects our own body. And then we all know that there are two types of immune disorders, autoimmune disorders like lupus, rheumatic arthritis, type 1 diabetes. They are partly hereditary, causes hypersensitive, but immune cells attack and destroy the healthy cells of the body. While in immune deficiency disorders, that can depress or completely disable the immune system and may be genetic or acquired, like we all know about AIDS, and cancers like leukemia and multiple myeloma. It is lately there is a lot of research has been going in the field of microbiomes. So much of research is going that how can they affect our nutrition and body health. It has been found that trillions of microorganisms or microbes in all over the body. They are much more than any kind of microorganism around us, and they play a key role in immune function. And gut is a major site for this activity and the production of antimicrobial antibodies. And diet plays a huge role by determining what kind of microbes live in our intestines. A high fiber plant-rich diet with plenty of fruits, vegetables, whole grains. We have been listening since last 2-3 lectures. They are responsible. They basically gives us the prebiotics by breaking these microbes break down the fibers into short chains of fatty acids and polysaccharides, and which is helpful to for the living of the bacteria. And the examples for that are garlic, onion, leek, asparagus, and many more fruits and vegetables which have lots of fiber in them. And then we all know that probiotic foods like kefir, yogurt, which with live active cultures is also very seen in the kimchi, tea, etc. is again very beneficial for our intestinal bacteria. Now, is there any relationship between immunocompromised patients or the malnutrition? Yes, it's a reciprocal synergism relation, and infection leads to deterioration of nutrient status because of immunocompromisation, and malnutrition increases the susceptibility to these infections in these patients. So we must understand this very well. This table I really like. It's very beautiful. It talks of malnutrition and infection, and there is an interaction at reciprocal and synergetic. You can see that nutrition status is equivalent to the health status, and if the health status is bad because of the disease, it contributes to malnutrition and vice versa. So this vicious cycle known as malnutrition and infection is very important for us to understand that any inadequate dietary intake leads to weight loss, growth failure, and reduced immunity, which is already reducing this patient while the body's ability to risk of infection is there. And this causes longer and more severe problem, and the disease episodes are worsened, and this further results to loss of appetite, malabsorption, nutrients altered, and it goes on in a cyclical form. So what are the effects of resistance in immune compromised patient. It can lead to reduce in body resistance to infections by reducing antibody formation, especially PEM. It production of non-specific protective substances like interleukins, lipozyme, hydrogen enzymes, phagocytic activity of macrophages, and non-specific resistance to bacterial toxins and inflammatory responses. The wound health is also becomes very healing becomes very difficult. The effects lead to micronutrient deficiencies. The VAD reduces the leukemia numbers, lymphoid tissue, T cell function, which is already reduced, and iron deficiency is also there, which reduces the cytotoxic activity of phagocytic, which is already very bad, and proliferation of helpers which are not there. And vitamin D deficiency, again very important for us because it reduces the lymphocytic number, which are already less, and lymphoid tissue and weight and antibody response and phagocytic function and T cell population. Zinc deficiency we have all seen in COVID era is very important because it is again immunosuppressant for our body. There is a profound effect on of nutritional status on intake, metabolism, and excretion of most of the nutrients. It causes protein catabolism, increases the resting energy metabolism, reduces the serum vitamin A concentration and precipitation of xenothermia, and it further the response is a deep effect on utilization of endogenous nutrient stores, leading to malnutrition. There is an increased energy expenditure about 10 to 15% per person per in case body temperature. The carbohydrate stores also decrease. There is an increased loss of poor absorption of nutrients and increased permeability of intestinal mucosa, which further a long association of microscopic blood loss leads to iron deficiency anemia. We all know that the most common immunodeficiency disease which we encountered in our practice is HIV and AIDS, and we all know that it has a very bad effect on our nutrition status. It depresses our appetite, the poor nutrient intake, and limited food availability. Fever, nausea, and vomiting and diarrhea are associated with this disease, which again gives rise to the negative effect. There is depression, which is again negative for the health, and increased energy requirement, 20 to 30% in symptomatic patient. Again has a negative, and side effects from drugs and opportunity infections further give rise to problem. The chronic infection we all know are there in this patient, which lead to malabsorption, metabolic disturbances, and in muscle and tissue catabolism. So general mechanism of infection is there is a shift in type and quantities of food consumed because of the loss of appetite. Adverse effect of treatment on nutrition is there. Sometimes we need to give purgatives to the children with diarrhea and worms, which is again or give prolonged antibiotics. That also interferes with synthesis of vitamins D in the body, and there is impaired absorption, and folate and energy and micronutrients are elevated to fight off the infection. Now, sometimes they have this parasitic organ infection. There is increase in urine loss of nitrogen, vitamin E, ascorbic acid, iron, zinc, and all minerals, and other sometimes the urinary schistosomiasis can also lead to loss of iron and protein, and there is increase in fecal loss, leaking gut phenomena is seen with these cases, and there is sweat loss and other problems there. Now we all know that these patients normally have a cachexia. We all know that there are three categories of cachexia: pre-cachexia, which is there from 6 to 9%, where there's just a weight loss. And then there is cachexia syndrome, where the weight loss and reduced food intake, and there is systemic inflammation, which again takes 3 to 9 months. And severe cachexia, there is severe muscle wasting, fat loss, and seen in immunocompromised patient, which is less than 3 months of time, and it creates all the problems. So what do? We give them, what changes occur in our metabolism. For carbohydrate, there is increase in insulin resistance, there is increase in glucose synthesis, gluconeosynthesis, there is increase in cholecycle activity and decreased glucose tolerance. While protein, there is increased protein, metabolism and decreased protein synthesis. There is an increased lipid metabolism, decreased lipogenesis, and decreased activity of lipoprotein lipase, which is again negative effect. And another factor which is responsible for this is the appetite. We all know the appetite is reduced in the patient, and which leads to not only endocrine abnormalities, but also intermediate metabolites, nutrition abnormalities, neurological influences, and psychiatric and psychosocial influences are also there because of this. And this secondary infections and other problems are there, so which affects the food intake. And there is a learned aversion to the therapy, and social and economic problems can also lead to decreased food intake. This has a negative effect on the patient's health. Now, how do we go about it? We need to assess patient by taking a detailed history like in any other problem. Look at the size, look at the weight, know the lab values, and plan the nutritional requirements, set a short-term and long-term goal, and individualize the need of the patient, and then intervene if the symptoms symptom management, and plan the strategy for whether patient requires oral or parenteral nutrition. We need to evaluate the effectiveness of intervention and achievement for long-term and short-term goals. So how do we evaluate? Before beginning the intervention, there are some cardinal principles. Individualize the need of the patient, look at the short-term goals, improve the nutritional status. Long-term goals are normalize the nutrition intake and alleviate the disease symptoms. And outcomes, we all need for everything, we need positive outcomes for better quality of life and vigor. And fewer crises and improved response is required in this treatment page. So what we need to screen and then assess the patient. So what is the meaning of screening? It is done to detect the possibility of nutrition risks. All patients in all settings require the screening, and it is required to be stored in the medical file and patient-related guides. And then we have to, when we are talking of assessment, it has to be more intensive, thorough, needs intervention and follow-up. Assessment must have not only weight, but also the appearance, functional status, biochemical parameters, and medication and plan treatment. And we must include financial and psychosocial aspect as far as possible, and it has to be done along with the help of a dietitian. And both of them have to form a team and talk about it. So when we do assessment, we have to do anthropometry to weigh a patient regularly, calculate her BMI, look at the weight loss, whether it is severe or less. Then mid-arm circumference has to be taken. Then in laboratory, may not always be very accurate if viewed alone. So we have to combine it with other parameters. Serum albumin levels for only after significant depletion. Serum pre-albumin can be assessed for assessment. Then serum transferrin, more sensitive marker for marginal protein depletion. Then in cases of anemia, we can do total iron binding capacity, delayed hypersensitivity skin, to recall what kind of antigen may be giving the problem, and total lymphocytic count. Then diet history is very important, especially 24 hours, and what is the food frequency. We have to go in the real detail. So who are the patients who are severely malnourished? The weight loss, if the weight loss is more than 10%, there is a poor intake for 2 weeks or more. The BMI is less than 18.5. Mid-arm circumference in cases of female is less than 17.1. And there is a subjective global assessment score of grade C, and mini nutritional assessment score less than 25. And albumin and entry is less than 3 grams per cent. Total lymphocytic count also less than 1500. Then we must be alert. So we must calculate calories as per the patient's weight. In obese cases, we must give less calories, 21 to 25. In non-ambulatory sedentary, 25 to 30. In cases of sepsis, again, we need to give more calories from 25 to 35. slightly hypermetabolic, or those who need to have weight gain, we need to give much more calories from 30 to 35, and hypermetabolic and severely stressed, again, we need to give more than 35. So what are the protein needs? We all know that there are normal or maintenance is 0.8 to 1 gram, while in non-stressed cancer patient, it goes up to 1 to 15 grams per kg. And in cases of bone marrow transplant, it is 1.5 gram per kg. Above was 1 to 1.5 gram per kg. There's an increased protein intake from 1.5 to 1.5 gram in some cases. And in cases of hepatic or renal compromised disease, it is further to be managed properly. So what are the vitamins we require more is foliate, vitamin C, retinol, and minerals. We all know they play a very important role: magnesium, zinc, and copper. Fluid requirement is again very, very important. We all know that from 16 to 30 years of age, we need at least 40 ml per kg, while from 31 to 55, 35 ml, and from 56 to 75, the fluid, as the age increases, the fluid requirement also decreases, goes to 30 ml per kg. And all women beyond 76 years, the fluid requirement goes below 25 ml per kg. So we need to very closely monitor the fluid in this patient, and 1 ml per kilogram of the estimated energy needs is also another problem. How do we manage symptom? Nutrition can help manage the symptom. The key is to start much early when the patient is not in the severe form, and then we have to do specific modifications with while minimum to minimize the nutrition related disorder. Each side effect has numerous approaches for management. We need to strategize the patients, including the teaching and trial and error method, and then screening assessment will identify which patient require what kind of intervention, whether it can be given orally or it has to be given on parenteral. There are many food safety guidelines which we have to keep in our mind, because these patients are already immunocompromised. They have to wash their hands, surfaces, produce, and clean lids for canned products have to be separately kept. They should not cross-contaminate separate foods and cutting boards, especially true for flesh foods. Then cooking has to be at a proper temperature. We use food temperature to take the, what is the temperature. If it is not cooked properly, there are risk of bacteria being there. Then we need to refrigerate it completely. Cold temperature slows the growth of harmful bacteria. While shopping also, we need to be careful and read all the labels for expiry date. As Dr. Lakshmi has emphasized the need for the, reading the labels, we must read about it. And we must be smart while eating out and transport food carefully and go by rules. Be aware of food-borne illnesses and keep away from all the problems. Thank you very much for this patient hearing.
Thank you, Dr. Anju. It is talking about the immunocompromised patients. Diet is a very, very special, super specialized field, because they definitely need a lot more particular points to be careful about it. And you also talked about the gut microbiome, which is
that is the latest research which requires more and more work, and the more work comes out, the more we will understand.
Yeah, what I was just thinking when you were talking about it, the Indian diet, which we used to take always, was focusing on a gut microbiome more. Now we are coming back to that the same.
Per se, the porridges, the full millets, that has been followed in all over the world, while we are shifting to the Western diet, which is the most harmful diet we all know of.
Thanks to now we are shifting back to Shri Anna, that the full grains now.
Yeah. So because that is the most harmful diet. It contains all the harmful. It doesn't contain any fibers, or it's very, very harmful. It is processed food. It should be avoided. Along with, of course, I didn't mention, but along with it, all these patients have to avoid smoking completely, and alcoholism has to be in very, very moderation, because that is also has a negative effect on the nutrition of the patient.
Yes, yes, and it's FS. So thank you, Dr. Anju Soni, and let's just start with the next talk. I'll
I would
share
like
my
to thank
screen.
Dr. Lakshmi and the whole of her team for organizing this beautiful,
Yeah, it is really
conceptualizing this beautiful programs. It's very beautiful. Thank you, everyone.
So I'll come back to our session as it was designed earlier. It's in between, as Dr. Jayanti was busy, so we had to shift to other Dr. Anju. Now Dr. Jayanti, she is here. I've just seen that she's so she's. Let me introduce her. She's Professor Ops and Gynae, KIMS, Bengaluru, past President of BSOG, past Senate member of RGUHS, past BOS member RGUHS. I wish I would have known the full name of
that is Rajiv Gandhi University of Health Science.
Oh, okay.
That is a board of studies. Board of studies. She's a member of past.
Yes, so very nice of it. Past treasurer, BSOG, joint
that is a
organizing.
Bangalore OBGYN.
Yeah, that I think everybody can understand. Joint organizing secretary, ICOG 2019. IEC and MEU member, KIMS, EC member, Bangalore Menopause Society, speaker at many conferences, publications, presentations, all of it, lot of many. And she's regional coordinator for PHFI, Contraception Association. This is the, I think, public-private partnership. Certificate course she has been doing 2014-15, and she's member PGCME committee, Bangalore Society of Ops and Gynae. So, madam, please talk.
Thank you so much.
I think you are going to talk on nutrition and the FGR basically. So I'll stop sharing my screen in a
Am I audible?
Welcome. Yes, you are audible. Welcome.
Share you are audible. Yes.
Okay.
And one more thing, I just wanted, we have been to there, Bangalore in 2019, and had the privilege of your hospitality.
Thank you so much. I hope you enjoyed the ACOG.
Yeah, definitely.
Okay. Now, good evening, one and all. And I would like to thank FOGSI and Dr. Vidya Tobbi for giving me this opportunity to speak on.
Ma'am, make it a full slideshow.
Yeah, I'll just make.
And Dr. Lakshmi also from ICOG.
Yeah. And I would like to thank Dr. Lakshmi, because of the slide sharing confusion. Yeah. Okay, I would like to thank one and all, and also good evening to all the viewers. My topic today is on nutrition and fetal growth restriction. So we all know that low birth weight is a major problem in our country. Almost about 3 million babies are born annually, incidence being 50 to 20%, and it accounts to 30% of stillbirths. And both undernourished as well as overnourished mothers give birth to undernourished babies. So nutrition, we know that it's a major interactive factor which helps in the fetal genomic development. And we know that fetal programming gives rise to fetal origins of adult disease, which is a well-known factor, and mainly changes in fetal nutrition and endocrine status, which causes alteration in both physiology, structure, and metabolism of the offspring, which leads to adult development of disease, mainly cardiovascular and endocrine disorders. We all know that placenta is essential part in maintaining fetal growth, and placental insufficiency is multifactorial. So for supply of proper nutrition, the main factors are thickness of exchange barrier, uteroplacental perfusion, and transporter capacity and concentration. So the placenta is an array of nutrients which are sensing signaling pathways, which coordinate and regulate the nutrient uptake and cellular signaling in response to both the maternal nutritional supply as well as fetal demand. These are all linked N-acetyl glucosamine transferase. They're the primary nutrient sensing proteins, and they help in utilization of both glucose as well as amino acids. And we all know that glucose and amino acids in presence of oxygen only are useful, and they're the major nutritional substrates which are helpful in fetal growth. So glucose is the primary nutrient required, and for this it is through the blood family of transporters. We know that glucose transporter system is very, very important, which is present in the basal side of the membrane. And usually it starts expressing from as soon as the placenta is formed, and there's a steady rise in these transporter system. And in the third trimester, it increases and reaches the highest concentration. That's why we see late onset FGR, which is very common, especially if it's nutritional. And one word about empty calorie. What does it mean? These are high energy foods, but with little nutritional values. that is wherever there's added sugars. I think already most of them have dealt with this. Soft drink, desserts, beverages, all these are called as empty calorie food. And at the same time, even fats like fried foods, cheese, and bakery items, and whole milk, all these are, with high calorie but less nutritional value. So these to be avoided in pregnancy in order to prevent FGR. In first trimester, we know it's organogenesis. The critical nutrients required include protein, folic acid, vitamin B12, and zinc. Whereas in second and third trimester, here energy intake is important because 90% of the fetal growth occurs here. So here protein, iron, calcium, magnesium, vitamin B, and of course, omega-3 fatty acids and docosahexaenoic acid have a role. And already Dr. Anju also spoken about the requirement. The extra calories required in second trimester is 360 kilocalories, third trimester 470, and lactation 500. And recommended protein 61 to 70 depending on the body weight, fat about 50 to 85, and fiber should constitute about 25 grams. Because constipation is quite common, that's the reason. And again, Dr. Anju has already dealt with this. Mainly, I would like to tell about the dietary sources: meat, poultry, fish, and eggs, and vegetarian foods, soybean, milk, soy products. And of course, nuts and legumes are very rich in protein. One precaution is commercial protein supplements are not recommended because they do not contain the proper proteins which are required to prevent fetal growth restriction. And we have complete protein foods and incomplete protein foods. Complete proteins are seen mainly in non-vegetarian, and apart from that in cheese, milk, yogurt, which provide all the essential amino acids. In incomplete proteins, vegetables, grains, nuts, seeds, legumes, etc., because they are incomplete because they may lack in one or more essential amino acids. So our native food, which is either roti, dal, or rice or sambar, where we have a combination, they supplement each other because we know that cereals lack in lysine and threonine, whereas legumes lack in amino acids of methionine and tryptophan. So when they are taken together, they cover up the deficit of each other. So vegetarians need not worry saying that they are taking incomplete. They can combine these combinations so that they have a full protein meal. We speak so much about arginine. So let's see what is the role of arginine. So arginine helps in maternal nitric oxide production, which in turn increases the uteroplacental perfusion, which helps in fetal oxygen and nutrient delivery and helps in fetal growth. At the same time, arginine also acts on maternal growth hormone, which again acts on placenta and which increases the fetal oxygen and nutrient delivery and growth. And again, maternal arginine also has a role in polyamine synthesis, which acts on the placental growth and development. So for a normal placental formation, which helps in fetal growth. Then fetal leucine. Fetal leucine helps in protein synthesis as well as it acts on beta cell. We all know that insulin is required for the development of fetus. So one is directly attacks protein synthesis and increases fetal growth, and indirectly it acts on beta cell and insulin release, which helps in fetal growth. Why is nitric oxide so important? Because it helps in maintaining a low resistance and high flow in the uteroplacental vasculature, so that proper oxygen supply is there. And when oxygen supply is present, only then the nutrients can be taken. So thus, in case of preeclampsia, if they already develop uteroplacental insufficiency, whatever supplementation, including L-arginine, may be ineffective because oxygen is necessary. So this is a flow chart where we can see that adaptation in protein turnover. So diet, if the diet is good, it directly helps in growth of placenta as well as even uteroplacental supply of nutrition. And only there the arginine transferase will help for fetal normal growth. Whenever there's hypoxia, because there's no transporter system proper and there is decreased transporter activity also, the food cannot reach the baby and whatever supplementation will not help. So these are the RCTs where they have done giving proteins. So one RCT where 44 pregnant women with severe vascular IUGR, mainly because of the preeclampsia, they found that there was no significant improvement in spite of supplementation of L-arginine, because L-arginine undergoes rapid metabolism by arginase in the liver and in the GIT. So there's very less availability of it, which NOS system can take up and supply the baby. So amino acid supplementation, either with L-arginine or citrulline, may be ineffective under conditions of hypoxia. Next is the fat. So fat, we know requirement is about 54 to 82 grams in second trimester and slightly more in third trimester. So precaution, because here we should not supplement too much of fatty foods because they are completely absorbed and they may cause increase in serum lipids as well as cholesterol, leading to dyslipidemias. So we should just give the required amount of fat. And as we know, most of us supplement even omega-3 fatty acids, which are essential fatty acids. Mainly they help in development of fetal brain and retina. Fish and other foods also are very good in omega-3 fatty acids, but one should be careful which fish to be given, because some of them may have increased mercury, and that may be harmful for the baby. And coming to the vegetarian sources, flaxseed oil, canola oil, rapeseed, soya bean, all these are rich in omega fatty acids, and they're helpful in fetal growth. So consensus guidelines have recommended at least 200 milligrams of DHA per day. Coming to the micronutrients, these are the requirements. I think most of you are aware of it: magnesium, sodium, potassium, iron, zinc, and iodine, which have some of them have to be supplemented. Coming to the vitamins, micronutrients: thiamine, riboflavin, niacin, B6, B12, BCA. These are the requirements: vitamin D, C, and A. And coming to vitamin A, the requirement, usually we do not supplement because the food itself contains vitamin A. And another problem is when we supplement more of vitamin A, high doses may result in birth defects. Vitamin D, we know again, it is commonly deficient in most of the population, even in Indian population. So here vitamin D supplementation is necessary, because not only vitamin D deficiency, it is required for calcium absorption. The most recent meta-analysis revealed that 25-hydroxy insufficiency during pregnancy may be associated with small for gestational age. And also a Cochrane review of 3 RCTs identified that vitamin D treatment alone significantly reduced the SGA compared to no supplements. So definitely vitamin D supplementation is required in pregnancy. Vitamin C, what is the role of it? It also helps in fetal growth. There's a study where multiple regression analysis after adjusting for Koreans, that is a Korean study, where they found that there's significant increase in fetal birth weight when they're supplemented with citrus fruits and vegetables. These are the micronutrients where it's available. Vitamin A, we know it's available in milk, cheese, eggs, orange fruits, yellow fruits. Vitamin B is legumes, whole grain cereals, nuts, seeds, green leafy vegetables. Vitamin C, I think this I'll skip because most of you are aware where it is available. Now calcium, it's again available mainly in dairy products, almonds, and green leafy vegetables. Zinc, lean meat, chicken, fish, sunflower oil, and pumpkin seeds. Pumpkin seeds are supposed to be very rich in zinc. And selenium is available in Brazil nuts, wheat germs, sunflower seeds, and oats. So calcium, what is the recommendation? Most of us know we have to supply it at least 1 gram. So most of the studies, they have said that less than 800 milligrams results in fetal growth restriction. And wherever they've supplemented more than 1 gram, that is around 1,200 milligrams, that there's apparent increase in fetal growth. And there's a reduced incidence of IUGR. Coming to iron, which is a very common problem in our country, it is very much required for fetal growth. And especially like all these supplementations to be done in early pregnancy to prevent PFTR. But the sad part in our country is that most of the pregnant women may attend clinics late second or third trimesters, where it is very difficult to correct it. We all know that heme iron absorption is better, and the main source is non-vegetarian source. Whereas non-heme iron, it is available in green leafy vegetables, legumes, and eggs. So heme iron is preferable, but for those who are vegetarians, even non-heme iron foods have to be supplemented along with iron supplementation. Coming to the folic acid, diet is, all diets are deficient in folic acid. So because folic acid is a specific type which does not generally occur naturally. That's why supplementation of folic acid is a must. And nowadays, most of the foods are fortified with folic acid, and that can be used. So what is the requirement of zinc? Because so much about zinc we'll be talking. So first trimester is about 5.5, second trimester 7 milligrams, third trimester it's about 10. So what does it cost? If it's inadequate, it is some of the studies have shown that there may be congenital malformations. So at least more 30 milligrams of zinc has to be supplemented. And vegetarians need more zinc supplementation because most of the vegetarian foods lack zinc. And these are the studies which say that supplementation of zinc is helpful, especially when their intakes are more than 6.1 milligram per day. Dietary intake zinc between 8 and 11 milligrams were not associated with the low birth weight babies. Whenever it was less than 6, they had more of IUGR. Iodine requirement increases in pregnancy definitely, and most of us know that TSH values are much lower cutoff compared to non-pregnant women. So here the daily requirement is about 3.5 micrograms per day or 200 micrograms, 200 international units. Food sources are seaweed, fish, egg, milk, dried legumes, dried vegetables, and fruits. So most of the diet may be sufficient, but if it is insufficient, then we have to take the history and then we have to supplement. Role of probiotics. So probiotics taken during pregnancy might help lower the risks of preeclampsia and premature birth, suggest observational research that is from the BMJ Journal Open. But timing of probiotic and milk consumption during pregnancy and effects on the incidence of preeclampsia and preterm delivery, not much of use. That is another study. So there's one study in Auckland where they studied the diet pattern, and they found that when they've taken traditional foods like fruit, vegetables, yogurt, lean meat, etc., there is less SGA compared to when they've taken the foods with I said nutritional empty calories. That is like bread, confectionery, soft drinks, all that. So there only the mothers gained weight, but they had high incidence of fetal growth restriction. So what are the foods to be avoided in pregnancy in order to avoid FGR? Raw or unpasteurized milk, unboiled egg or uncooked egg, undercooked meat and poultry, and fish or shellfish where mercury can harm the developing nervous system of the fetus. So foods that are low in mercury, that is the fish, are salmon, tilapia, trout, pollock, and catfish, whereas the swordfish, tilefish, and the king mackerel, which commonly consumed, are very high in mercury content. What about total parental nutrition? Does it help? No, it does not help at all, except in hyperemesis where there's actual deficiency and in malabsorption, but otherwise in FGR it does not help. And next is smoking. So women who are able to stop smoking by 15 weeks of gestation can reduce the risk of IUGR compared to non-smokers. It may be when they stop smoking, their incidence becomes equal to the non-smokers. That is when they should stop it in early weeks of gestation. Later weeks, it will not help. Caffeine. I think all of us are very fond of coffee. So moderate intake, that is less than 300 milligrams per day or 2 to 3 servings are they're not do not cause any adverse side effects, and comfortably they can consume. But more than 500 milligrams, it is that causes spontaneous abortions in first trimester, and also later it may decrease the bioavailability of iron, calcium, and zinc, which may lead to various deficiencies and fetal growth restriction. In 2015, they studied about healthy eating index, which was developed here. Based on 13 nutritional components, they scored between 1 and 100. So high HEI score equates to a healthier diet, and low means it is unhealthy. So when they did a study, 17% of moms who had high HEI, while 80% with a lower HEI score they had, out of which the ones with higher HEI had less fetal growth restriction compared to those who consumed more foods with HEI. So in conclusion, the study uncovered an association between fetal growth restriction and diet quality. So mainly good quality of food definitely decreases the incidence of fetal growth. So high intake of foods which are recommended are vegetables, whole foods, greens, most of the vegetarian foods, and apart from that, even red meat is very useful. On the other hand, too much of added sugars or sugary drinks and those with low HEI scores should be avoided in pregnancy. They only help in putting on weight to the mother, but does not improve uteroplacental nutrition. This is another study where they found that high quality diet is very important to prevent fetal growth restriction. Now to summarize, don't overconsume calories in general, since too much weight gain and obesity during pregnancy also is associated with FGR. The required calories only is about 300 to 500. Include plenty of good quality proteins and healthy foods like eggs, beans, legumes, etc. Make sure adequate folic acid, calcium, iron, zinc, and vitamin D is supplemented, and eat at least 5 or more servings of high antioxidant fruits and vegetables each day. And of course, green leafy vegetables, oranges, etc. Meat, unpasteurized dairy products. Reduce intake of processed meats, deli meats, etc. And seafoods also have to be selective with low levels of mercury. So balanced diet will take us a long way in preventing fetal growth restriction. So to conclude, steps to a healthy pregnancy includes eating a balanced diet, gaining right amount of weight, enjoying light regular physical exercises, and taking adequate supplements, avoiding all the unhealthy foods, smoking, alcohol, and processed food. Thank you all.
Thank you, Dr. Jayanti. It was a very nice, enlightening talk. And the most important thing, I think, with all these lectures, our attendees must be realizing that how much important is the nutrition, which we do not actually give much time. So as rightly said by previous speakers, spend 5 to 10 minutes and explain the diet. Like in IUGR, not really documented or well proved any treatment is there. It is better to maintain it early pregnancy, night nutrition, and avoid the occurrence of the IUGR, that is what an antioxidants and particularly high energy diet. How I mean antioxidants are important and HEI foods are not to be given. So thank you very much for giving the elaborate and fine details of it. So Madam.
And one more thing I want to add here is HEI index. What
Yeah.
Dr. Jayanti pointed out, we never take it into account.
I think we
Yes,
should
so-
have an HI, the table we should have and give it to all
Yes.
women.
So,
that they know.
yes, you can give it. I think, Madam, you must be sending the recordings to everyone, probably, Doctor.
Yes.
Yeah, because I mean, in one go, you cannot remember all those
Yeah, we
things.
cannot cover all the things. At
Yeah.
least
Yes.
nutritional
yes.
risk assessment, that much at least we can follow, and the diet chart, diet recall. We never take into account the calorie count, what she eats, what is the available food. All those definitely account for that. So
Very important.
let us
Very,
move
very
to the
important
next
for
talk,
that.
and Jayanti,
Yes,
be
I'm sure.
on board if any queries are there.
Yeah. Any
Sorry.
queries? Most
So,
welcome.
Till now, there are
please
no
stop.
queries.
If you, Dr. Jayanti, will stop
Yeah.
sharing, then I
Yeah.
can.
Sure.
Dr. Shilpa Joshi has joined. Her talk is next.
Okay, yeah, I'm going to share the screen for her. So,
Welcome, Dr. Shilpa.
Thank you so much, ma'am. Thank you.
Thank you.
just a minute. Yeah, so actually now it was supposed to, the second session was supposed to be started, but we have taken the talk of Dr. Anju earlier. And so now welcome Dr. Shilpa. Dr. Shilpa is from Mumbai, consultant dietitian, Mumbai Diet and Healthcare. I'm sure you must be analyzing for a very long time and you must be listening about our talks. Practicing dietitian. I mean, what the doctors in because we had super specialized talks in every field, FGR, diabetes, hypertension, there are different things. So she has also been Vice President of Indian Dietetic Association and Honorary Secretary, All India Association of Advancing Research and Obesity, Master Trainer, Course Director of some diabetic educators, and presented at various national and international meetings. Her the papers, runner-up recipient of Wim Hemer Guggenheim's International Essay Award, that on malnutrition, which is actually the most important thing to be avoided. And she has also been awarded three award by FOGSI in 2019. So Dr. Shilpa, I welcome you again. And I think you are going to talk about obesity and nutrition. So Dr. Shilpa, you are here?
Yeah, I am here.
She's very much
So
here.
I'll stop the share and you
Yeah,
please.
please. Yeah.
Thank you so
Shilpa
much.
was part of my various series on nutrition during my chairperson, I was chairperson Food and Drugs and Medical Surgical Equipment Committee.
Very nice.
And people have responded very well to her talks. And that's why I have called her on this board.
Yeah, and this
enlighten
PCOS
us
is such an
about
important thing.
Yes.
Explaining everybody about the diet becomes a real exercise. So welcome, Dr. Shilpa.
So thank you so much, ma'am. And thank you, Vidya, ma'am, for having me here. Very, very honored to be among all the esteemed gynecologists here. So today I'm going to be talking about PCOS and nutrition. And, I've been hearing talk, and there are very elaborate talks which have been given about various aspects of nutrition at various points. I'm going to be talking about PCOS nutrition, but there is only so much that you can cover in 10-15 minutes. But what I would highly recommend is, if if you can follow one of my pages, there is a lot more dietary clues that I give on week basis, which can be taken up by your patients, or even if you are interested, you can go on there. So we all know that lifestyle modification. So again, this is an August audience, and I really do not need to speak about what is the reason why there is PCOS. So we know that there is insulin resistance, obesity. We also have a huge section of people, women who are lean PCOS, but also are insulin resistant. And if you actually do their body composition, you realize that there is much more body fat in these women. They are sarcopenic. They have very little muscle mass, and these are lean women who also develop PCOS. And there have been enough and more research to show that even in lean PCOS women, you will find that nutrition becomes an important target for prevention and therapeutic intervention both. And lifestyle modification, which includes diet, exercise, and whatever appropriate drug therapy that you all give, is really important in management of women with PCOS, hyperandrogenism, and also in obesity, especially to decrease abdominal fat. And also, other metabolic parameters which come with PCOS, maybe a bad lipid profile, cardiovascular risk later on in the age, high uric acid. So any kind of metabolic component which is there along with PCOS can all be taken care of with lifestyle modifications. And again, there are more researches to show that lifestyle modification program, which includes diet and exercise in obese subjects with PCOS, actually not only improved physiological outcomes, but they also improve psychological outcomes. Because for a woman to look pretty, to look a certain way is very important. And it has been seen that post lifestyle modification program, there is improvement not only in physiological or reproductive outcome, but there is a huge amount of improvement in self-esteem, anxiety, mean depressive scores, etc. in women who follow lifestyle intervention. And again, how much is, we know that weight loss is recommended for women with PCOS, but how much is that weight loss that we are looking at? So a minimal amount of 5 to 10% weight loss over a month or so, where you will find that there is great deal of improvement in women with PCOS. So weight loss is thus a desirable outcome in overweight women with PCOS for both treating acute clinical and long-term metabolic health complications. And we all know what lifestyle modification entitles. Lifestyle modification involves altering long-term habits, typically of eating or physical activity, and maintaining this new behavior for months or years. Lifestyle modification can be used to treat a range of diseases, including obesity. So this is a classical definition, and therefore, we always tell the patients of women with PCOS or anybody who comes to us with a lifestyle issue, we always tell them that when you mean lifestyle modification, don't look at that 3 months or 6 months or 1 year program. In that 3 months, learn enough so that you can apply it to a lifetime. So a lot of times when people say, when they come to us and they say, madam, ye 3 mahine karna hai ya 6 mahine karna hai, we tell them ye 3-6 mahine nahi, ye zindagi bhar karna hai. So remember, it is a life altering thing that you're doing. You're unlearning and relearning a lot of things. So again, we know lifestyle has many facets. The more important facets which are known are, pardon me, diet and exercise. But a very important facet which is never spoken about is actually behavior therapy. And I think this is something which is very important to be considered. And again, these are, again, for this August audience, I do not need to speak about this. Again, fertility fitness program, where they did a dietary and a psychological intervention. They found that there were a lot of improvement in all kind of fertility, this thing. So these are again a few more data about long-term lifestyle modification programs. There are 48 weeks program, etc., where nutrition and even in some programs metformin was given, and they showed that nutrition, exercise was as good or even sometimes better than metformin in these groups. Okay, so now I'm going to go to nutritional intervention. So we know that there are changes in eating pattern in menstrual cycle, and menstrual cycle actually alters women's energy, macronutrient intake, and energy expenditure. There is changes in feeding behavior during menstrual cycle, and they have been well documented. There is increased fat and total energy intake during the luteal phase. This may be related to increased energy requirement, and loss of this cyclical change in energy utilization may contribute to increase in weight that commonly occurs following menopause and probably also in PCOS. So what is the effect of insulin and other hormones in PCOS? So hyperinsulinemia is one thing that contributes to increased androgen production in response to LH in the ovary, and also leads to increased level of free androgen by decreasing SHBG. Now the bigger problem is hyperinsulinemia. Yes, it is innate, but hyperinsulinemia is exacerbated when you eat high carbohydrate food. So as it is, women are hyperinsulinemic, and when they start eating high carbohydrate, high glycemic foods, you see that hyperinsulinemia actually goes up. Leptin is a hormone that is produced by adipocyte and is responsible for decreasing in feeding. It is also involved in regulation of reproductive function. Decrease in leptin production with weight loss may help to normalize reproductive function, and increase ghrelin levels in patients with PCOS may be a part of abnormal stage of insulin energy balance. And this abnormality again is restored towards normalcy with caloric restriction and weight loss. So actually what caloric restriction is going to do is decrease the ghrelin level, decrease hyperinsulinemia, and help you to restore a leptin balance. Okay, now weight. Now that this is one of the most important thing when we talk about women with PCOS. So there is an impression, but there is no clear evidence from published literature to show that women with PCOS find it harder than average women to lose weight. And this is something we talk about, we see with our patients in clinic that, they keep on saying that, I do everything and it's really very important, difficult for me to lose weight. So this is a problem. Improvement in abdominal obesity and insulin sensitivity may occur without overall change in body weight. So it is very important to realize that sometimes there is no loss on scale, but if there are loss in inches, there is an improvement in the waist circumference. You will find that lot of parameters in PCOS improve. Body composition of patients who exercise regularly may change with increased lean body mass and decreased fat mass, but there may be no overall change in weight. Increased lean muscle mass with increases the resting energy expenditure and actually may improve hormonal and metabolic profiles in women with PCOS. Benefits of modest weight loss have become more widely appreciated, aiming for as near body weight and composition as possible and wherever it is feasible. This is also very important while dealing with lean PCOS. So it is not only in women who are overweight, but also lean PCOS. It's very important that you get your body composition right. So if there is increased fat percentage and there is sarcopenia, you see to it that even though there is no weight loss, sarcopenia is corrected, body fat percentage is dropped, and that will come with doing the following changes that I'm going to say. Appetite regulation is a huge problem in PCOS. Both insulin and blood glucose fluctuate more widely in patients with insulin resistance and hyperinsulinemia. And we know these fluctuations give rise to hypoglycemia. So many women with PCOS will describe carbohydrate craving and cite this as a reason in difficulty losing weight. Mujhe khane ke baad, I need a piece of sweet. Otherwise, I go crazy. I feel, I don't feel correct. So this is usually happening because of reactive hypoglycemia that typically sets in because of hyperinsulinemia 2 hours after eating. And you find that women with PCOS after a large meal also 2 hours will go searching for a snack, for a sweet, for a fruit, but they will eat. So this is because of reactive hypoglycemia that tends to happen. So fluctuation in blood glucose may thus arise from the changes that occur in PCOS, but may also contribute to altered feeding behavior, body composition, and insulin responses. So now calories in PCOS benefit with even 5% of weight loss on well-being increased insulin sensitivity, and improvement in cardiovascular risk profile. Modest weight loss is achieved in short term and it may also improve hyperinsulinemia. So we know that other hormones also, that normalization of LH pulse frequency, etc., also comes back with caloric restriction. Okay. Now meal frequency. Now there is a lot said about meal frequency. We have people who eat every 2 hours, and then we have people who do intermittent fasting, and everybody is confused as what is the meal frequency, what is correct. So very little research is done on influence of eating pattern on metabolic parameters. Those who ate frequently during the day had higher intakes of carbohydrate, fiber, and a range of micronutrients. Those who ate less frequently had higher intakes of fat, cholesterol, protein, and sodium. This is what international data says. But what do we see in India? This is not true in India. Even if you ate less frequently, you still ate carbs and fat only. So even if you say didn't eat breakfast, in lunch you are going to eat roti sabzi or whatever, and that is only carbs and fats, and there is nothing else that we eat in India. Breakfast consumption was associated with lower energy intake and improved insulin sensitivity as compared to breakfast omission. Optimal frequency of food intake has yet to be determined, but a regular pattern with a low intake of snack seems to be desirable. So there are a kind of people who are called as grazers, who will eat every 2 hours, and that is a dietary pattern that is not good for women with hyperinsulinemia, because every time you graze, you are going to up the secretion of insulin. And in India, a country like India, every time you graze, you do graze on carbohydrates. They may be good carbohydrates, but they are carbohydrates nevertheless, and they will increase your insulin levels. Ghrelin levels increase in response to anticipation of food. Okay, a strong argument for regular but not too frequent eating episodes in individuals who wish to control or lose weight. So even a thought that, it's 5 p.m., it's snack time, or it's 7 p.m., it's this time. So even anticipation of food can increase ghrelin level. And if you have more anticipation of food every 2 hours, you find that this actually works against your weight control program. Now, there are many dietary strategies and composition and lifestyle modifications in PCOS. One of them is low-fat, high-carbohydrate diet. So this is an old approach. So, when I was a student, I remember there used to be a lot of pride in planning a very low-fat diet, because low-fat diets were in. And what it was shown that low-fat diets actually do not help you to improve hyperinsulinemia. That is because if you're eating low-fat, and in a country like India where you don't eat much proteins, you tend to eat a very high amount of carbohydrates, and usually all carbohydrates are not low glycemic index. And therefore what happens is you see triglycerides increasing, you see insulin levels increasing, and therefore, as long as you can choose very low glycemic foods, only will high carbohydrate diets work. Now, there are studies which show replacing protein for a carbohydrate. It's a busy slide, I know, but this is just to show you that there is a lot of data on it. I'm just going to give you a gist that when you replace protein for carbohydrate, there is a lot of improvement in hyperinsulinemia. So I'll give you a simple example. There is also a lot of decrease in ghrelin levels. So, typically in morning in India, we typically eat breakfast, which is poha, upma, idli, dosa, bread, parathas. All of these are high carbohydrate foods. The moment you replace these high carbohydrate foods with, say, sprouts or, say, dal dosas, or not adding rice to the dosa batter, or maybe eggs, you see that your hunger or your ghrelin response decreases. So you're not hungry within 2 hours. If you eat a carb-rich breakfast, you'll find that in 2 hours, you are looking for something to eat again. Even if it's between your OPDs, you're finding something to eat. So if you replace carbohydrates for protein, you will find that your hunger decreases, and this is a great way to control insulin levels and weight, and therefore PCOS. Okay, efficacy of very low carb diet. Now, what is the difference between low carb and very low carb? So low carb in Indian scenario, so don't go by what Western literature says, because their natural carbohydrate intake is about 50%. Our natural carbohydrate intake is about 70%. So when we are looking at low carb diet in India, we are looking to the tune of 40 to 50%. Very low carb diet, which is internationally approved definition, is 5% carbohydrate diet. So the efficacy of very low carbohydrate diets for women with PCOS have not been evaluated, but promises to be of considerable interest in relation to Insulin sensitivity. So we see very low carb diets have great results on insulin sensitivity. But what is the problem? A, that these diets have not been studied beyond 1 year. So all the diets that have been studied are for 1 year are not in women with PCOS, but with women with individuals with diabetes. And we do not know what happens after 1 year. In Indian scenario, what happens? If you tell people never to eat roti, rice, millets, people are going to get crazy. People will not know what to eat. It's okay to kickstart a weight loss program where you're doing this for 10 or 15 days. But after that, you need to give them some cereal because we are a cereal bound nation. Cereals are our food in general. So these are guidelines which are given again, the regular ones, that you decrease the carbohydrates, you do a caloric restriction of 500 to 1000 kilocalories per day. Now, there were so many speakers before me who spoke about caloric restriction. So do not start with a 500 caloric reduction because the patient will never come back to you because it is too little food to eat. So start modestly, start with maybe 200 or 300, and then gradually go up to 500, 800 kilocalories over a period of time. And look at the bread and cereal servings. Just 3 servings a day is what is spoken. So in a day, you can eat 3 rotis or maybe 3 cups of rice or something or the other, something similar to that. So these are just recommendations which I have taken. Okay. Now, meal replacement strategies. Now, what has happened is a lot of times in busy people, you can think of yourself, some young doctors say who has PCOS, or a young IT professional who has PCOS, or somebody young who is in marketing job and who is, on their foot, and they really don't have time to sit and eat or carry a snack with them or carry a full-fledged meal with them because they are, they're eating on go, or they're eating between OPDs, or, there is no time to sit for a proper meal, or they are in college, they are eating between labs and lectures and so on and so forth. You can find that meal replacement is a great strategy. All you have to do is open a powder, put water and drink. Again, am I recommending this? No, I'm not recommending. But the point is that we have people with different problems. So there are people like I live in Mumbai, and people leave home at 8 a.m. in the morning and come back only at 9 p.m. at night. They eat all meals away from home, and it is only possible for them to say carry 2 packed meals. It is not possible for them to carry many more meals. And eating outside the house, anything that you choose is really not healthy. And not every time is it possible just to eat a fruit and call it a meal. So sometimes you need a little more. Also, we know that fruit is a very poor choice of a protein. There is no protein in fruits, and therefore, a lot of times meal replacement strategies become a great strategy for choosing. Now, do not think meal replacement are protein shakes. They are 2 different things. Protein shakes are shakes which only have protein. Meal replacements are drinks which have protein, carbs, fats, and vitamins and minerals in the right quantity so that they mimic your meal. So protein shakes and meal replacements are 2 different things. And there are a lot of data from a lot of studies to show that meal replacement actually helped in weight loss in women with PCOS. And so there are many studies. I've just put in here few studies to show you. Now, another diet which has been proposed is the anti-inflammatory diet, because we know PCOS is a pro-inflammatory state, and diet also induces inflammation. And we know, especially in India, diets are very high in glycemic index because we tend to choose a lot of cereals when we eat. We choose very little protein. Even the choice of vegetables that we have is very starch bound. We have potatoes in most of our vegetables, or we love to have aloo ki sabzi as such. So our diets are very, very high in glycemic index, and we know obesity as such is a pro-inflammatory state, and therefore decreasing inflammation becomes very, very important. So what is the principle of anti-inflammatory diet? Diet should be low in glycemic load. They should be low in omega-6 fats. These are the oils that you are consuming. So whichever oil you choose, say a corn oil, a sunflower oil, a safflower oil, these are very, very rich source of omega-6 fat, and we need to decrease them and increase EPA. Now, whatever omega-3 fats which are present in vegetarian sources, okay, will be either alpha-linolenic acid, that is the vegetarian form of omega-3, or if they have long chain fats, they will be only eicosapentaenoic pentanoic acid. Docosahexaenoic acid will be only present in fishes. So you cannot get DHA from plant source, but you can get EPA and you can get alpha-linolenic acid from plant sources. So carbohydrates in anti-inflammatory diet, it is recommended that one has to consume only about 150 grams of carbohydrate, which is coming from low glycemic sources, which can be achieved by consuming about 10 servings of non-starchy vegetables, limited amount of fruit because of their higher carbohydrate content. So they are not saying don't eat fruit, but they are not saying to eat plenty of fruit. So you need to eat a limited amount of fruit and relatively rigid, but not total exclusion of high glycemic carb-loaded cereals such as bread, pasta, rice, and potatoes. So if you take it to India, it can be roti, rice, potatoes, sweet potato, so on and so forth. Protein, we need about 100 grams of protein in this diet, which comes from either, if it's non-vegetarian, fish or chicken. If it's vegetarian, then dals or tofus. Limited amount of soya beans, so on and so forth, because they will induce satiety. Now, fat about 50 grams per day, which are not coming from omega-6 sources, limited amount from saturated fat, but which are coming from long-chain omega-3 fatty acids, which can come from a lot of algal sources, which can contribute to EPA in the diet. So macronutrient composition of an anti-inflammatory diet is usually considered as 1-2-3 diet. 1:2:3. That means for every 1 gram of fat which is consumed, one individual will consume 2 grams of protein and 3 grams of carbohydrate, which are coming from non-cereal sources. And this ratio stabilizes postprandial insulin levels, thus relieving inhibition of hormone-sensitive lipase in the fat cells, and it actually helps you to reduce silent inflammation. This is a great diet to be consumed. So the additional benefits are many, many more besides anti-inflammation. Main thing is weight loss that comes from it. And then there is a lot of role of spices in anti-inflammatory diet, and one of the spices which is commonly used. So there are many, I'm just alluding to one, which is used very rampantly and liberally in Indian diet is haldi or turmeric. And you will see that it actually helps to scavenge radicals which induce damage to DNA. So this is really, really anti-inflammatory in nature. And then there is something called as dietary inflammatory index. And again, there is a huge scoring for dietary inflammatory index. And that actually has shown that if you are, even energy has a positive inflammatory effect, so does carb. But if you look at fiber, it is anti-inflammatory. If you look at all the vitamins, they are anti-inflammatory in nature. So, if you have, that is why more fruits, more vegetables, rather than cereals and other things, so that you get a lot of anti-inflammatory foods, which are, so any negative number shows anti-inflammatory effect. Positive number is a pro-inflammatory food, and you will see energy itself is extremely pro-inflammatory, and hence low calorie diet is what is expected. So what are the changes to Indian diet to get into anti-inflammatory diet? Less emphasis on carbs, roti, rice, and millets. More emphasis on pulses and dals. Lots of locally grown non-starchy vegetables like butter gourd, ridge gourd, various green leafies, beans, drumsticks, so on and so. Less emphasis on N6 oils, use of Mufa oil as a preferred source of cooking, like groundnut, rice bran, mustard, so on and so forth. Inclusion of nuts like walnuts and almonds for ALA, that is alpha-linoleic acid and Mufa content. Inclusion of fish or fish oil supplements, and moderate use of locally grown, less sweet fruits like jamun, guava, bear, so on and so forth. So try to look at eat local, eat seasonal. Okay, then there is one thing which I'm going to allude to. I know this is getting into intricate dietetics, but it is interesting. Advanced glycation end products which are coming in our food. So we say, right, baking is a very good method. But remember, when you bake, you have a lot of advanced glycation end products in your food. And these are really extremely pro-inflammatory. They will cause chronic diseases. And this is the whole cycle. So, when you bake a cake, you get nice brown crust. Or when you make a kadak roti, you get a nice brown crust. They are all advanced glycation end products, which are really not good for you. Actually, when you go to restaurant, we say kadak roti bana, so that it's fun to eat it, but they are really not good for you. And that is why you'll find that boiling is a preferred method of cooking rather than grilling. So a lot of times when people come to us for weight loss, we tell them chicken khana hai to tandoori chicken khao, because there's less fat in it, right? But what happens is tandoori chicken is full of advanced glycation end product. So I want to tell them to eat poached chicken or chicken in a soup, or grilled vegetables ke bajaye steamed vegetables, or vegetables in a broth. So these things become very, very important because cooking methods are important. See, have you ever wondered, we all try to follow such healthy diet, but we never talk about cooking methods, and that's actually how macronutrients and micronutrients get exposed to your body depends upon how you cook the food. If you fry the food, you're losing everything that was present in the food. So, you may fry an apple and you're not going to get anything out of it. So how you expose the food, how the food matrix is exposed to body is very, very important. And that is why any food which has Millard's reaction, which is the browning reaction, kadak roti, kadak bread, kadak whatever, is the Millard reaction, which gives you aroma, color, and flavor, is going to spoil the food itself. So next time, please don't order anything kadak, order everything which is poached in water. So these are all. So again, I think I have just, so pointers to choose food. No, I think I have in, okay. So try to choose foods. Okay, so there is some examples. Poached or steamed chicken has 1/4 advanced glycation product as compared to roasted or broiled chicken. So this is a simple example. So scrambled eggs prepared over an open pan over medium heat has half the age products when it is prepared over high heat. So, if you have cooks at home or you have maids at home who cook your food, tell them to cook slow. When they cook slow, the food is treated better and it is better for you. Okay. One last slide, seed cycling. I'm sure all your patients talk about it. It's a naturopathic remedy. Now, whether it works or it doesn't work is very, very variable. I have given it to a lot of people. In some it works, in some it doesn't work. But nevertheless, I'm going to tell you what it is. It claims to balance hormones by regulating hormone estrogen in first half of your cycle and progesterone in second half. There is a lot of anecdotal evidence about its usefulness. Scientific evidence is not present, but every woman with PCOS who comes to me first asks me about seed cycling, and hence I'm putting it here. So it involves eating seeds, which are flax seeds, pumpkin seeds, sesame seeds, and sunflower seeds at different time of month to balance certain hormones. So in follicular phase, 1 tablespoon of freshly ground flax and pumpkin per day for first 13 to 14 days. In luteal phase, 1 tablespoon of sunflower and sesame seed until the first day of the next period. This is what is done by the naturopathy doctors, and this is very popular among women with PCOS, and it is shown to normalize the menstrual cycle. Okay, so in conclusion, nutritional management is cornerstone for managing PCOS. Caloric reduction is important, especially in obese overweight women with PCOS. Reduction in carbohydrate, choice of carbohydrate is important. Fiber is the most important carbohydrate in management of PCOS. Proteins are important for early satiety and ghrelin suppression. And hence, whenever a woman with PCOS eats food, she should ask this $1 million question, where is the protein? And if she doesn't find answer to it, she better not eat food. Invisible fats from nuts, oilseeds are important in management of PCOS. And cooking methods and processing food is as important as selection of food. And we very often never speak about it, because we feel that what can we do, how people cook food. But I think how people cook food is very important as what they eat. Thank you so much for a patient hearing. I'll be happy to answer any questions if there are.
Thank you, Dr. Shilpa. It's a very, very informative talk. And in fact, when you were talking about advanced glycation index, I was also thinking, we also like kadak roti and kadak things. So now we'll have, you have made us, it has to be stopped, because otherwise the advanced glycation products will be, which you said is harmful. Even seed cycling, it's a very, it's a new, concept. Read it, but not in so detail that how you have to give different seeds into the follicular phase and different into the luteal phase. I am sure these things, you can put them a small summary of these things into the group, so one of these people can take advantage of it.
And there are two questions, I think. Enumerate food to be consumed as a fats and EPA rich foods. So they want, and there are so many compliments for Shilpa.
Thank you.
So two things.
So you want me to put answer in the chat box or give it away?
No, you can answer now
Okay.
itself. Yeah.
So EPA-rich foods will be products from algae. So if you go in the market, you will see vegetarian omega-3 fatty acid capsules, which come from algal sources. They are having EPA. But if you're looking at walnuts, if you're looking at flax seeds, they are going to give you alpha-linolenic acid. They are not going to give you EPA. Conversion of alpha-linolenic acid to EPA in our body is 5 to 7%, and it is genetically determined. So whether you convert that much. So it's better if you're looking for EPA, look at algal sources of omega-3 for vegetarians. And of course, if you're a non-vegetarian, any kind of fish oil will have both EPA and DHA. And what was the other question?
Elaborate on the fat which one should, which
Fat?
I mean with fat into the diet, which one should take?
Oh, okay. So this is a question which is always asked to me. So it's a repetitive answer. So first thing is, whichever fat you consume, wo chand pe se bhi aaya, to bhi it has to be consumed in a limited amount. So first is 4 teaspoons of visible fat per person per day. 4 teaspoons, not tablespoons. So 20 grams of fat per person per day. The choice of cooking oil, considering Indian cooking methods which involve very high heating of fat. So when you cook any Indian food from Kashmir to Kanyakumari, the standard is a tadka. You heat oil and you wait for either rai or jeera to splutter, which splutters at 200 degrees. So you need a fat which is very resistant to that heating, and that is a monounsaturated fat. So choose a fat which is coming from, say, mustard oil, groundnut oil, sesame oil, til ka tel. These are fats which are resistant to high heat. Do not choose a sunflower or safflower oil, which are omega-6 rich, N6 oils, which will get denatured by the time you take them to 200 degrees Celsius. So this is an important choice. But more important than that is that you choose fats which are invisible in nature. So nuts and oil seeds are a great source. So please eat nuts and seeds every day. Seeds more important than nuts for 2 reasons: lower in calories and also cheaper. So for your patients
What
also,
about ghee? What about ghee?
So in this 4 teaspoons, there can be a teaspoon of ghee. So then you make 3 teaspoons of oil and 1 teaspoon of ghee.
Okay.
And there is one more question on microwave heating.
Okay, so microwave heating is very controversial because data is very limited. So what happens in microwave heating? In microwave heating, microwaves actually make molecules of water move while it is being heated, and that kinetic motion of water molecules heats the food. Now, there are a lot of people who say it's bad and carcinogenic and this and that, but there is no data to show that. So this is all there in anecdotal literature, but not in real life. So my suggestion is, I know what my suggestion is too ideal and it doesn't happen in real life. Try not to reheat food as much as possible. Every cycle that you reheat, you are losing vitamins, you're converting fats into trans fats. So वो पहले ज़माने में, it used to be mother used to cook food and kids used to eat, and that would be never reheated. That's the best way to eat. But if you want to reheat on a flame and reheat once. So what happens is typically dal and all is reheated and again, whereby you're destroying the nutrients. So take it out in a small bowl, just warm what one person needs if it's getting reheated. Don't reheat repeatedly the same food again and again. That's very, very important so that you get enough nutrients every time that you eat.
Yes. And what is your prescription for lean PCOS? This is a common question.
So lean PCOS is very important that you give a high protein, moderate carb diet. So, what happens is when lean PCOS girls come with their mothers and you put them on a calorie restricted diet, this happens especially when they come to us, they say, ab to wo dikhegi nahi, as it is, she is so thin. If you put her on a calorie restrictive diet, but her body fat percentage is still high. So she might lose a kilo or 2 in the process, but you will see that her body fat percentage will drop, protein percentage will improve, her muscle mass will improve, and then she'll start looking not as lean as before.
There is another question. What about the food you keep in fridge?
Okay, so there are 2 ways again. So if you're keeping a cooked starch in the fridge, so just giving you a dumb example, but I think a lot of you will relate to it. You make rice at night or chapatis at night and you keep it in fridge. Then when you eat next day, this starch is getting retrograded, and retrograded starch is really good in management of problems. So if you have diabetes and if you eat a previous day ka rice or chapati, your postprandial rise will be much lesser than eating a fresh chapati. It's called as a retrograded starch. It's a heated, cooled, reheated starch, which is good for you. But if you're talking in terms of micronutrients, it's bad because you're losing them all.
Okay. So I think now many, obviously the questions will
Many
never end.
questions for Shilpa and they will never end. So let us move. She will answer in the chat box and let us meet her again.
Yeah,
So
yeah,
we'll
yeah.
move for the next
So
talk.
yes,
Thank you
yes.
very
Thank
much,
you, Dr.
Shilpa.
Vidya. So now I'll share the screen and we'll
Thank
go
you
to
so much for
next.
having me here. Thank you.
You are
Very
welcome,
much.
always, all the time. Let me go to the next person. So we have Dr. Nalini Anand with us. And as you know, she is, just a minute, my screen sharing. So Dr. Nalini, presently, I'm not able to see the first line of it because some screen issue. She's a treasurer, Jamna Nagar
No, she is the professor, head of the department.
Yeah, well, actually, I'm not able to see that.
No, that's what I'm reading here.
Yeah,
And
yeah.
I know her personally. So Dr. Nalini is a professor, head of the department, MP Shah Medical College, Jamnagar. She's a senator of Saurashtra University and treasurer, Jamnagar OBGYN Society.
Yeah, and
she was a president also, Jamnagar OBGYN Society, and many posts at her
and
credit.
she's held many posts of like organizing secretary of ICOG, governing body member of ICMR. She has a keen interest in high-risk pregnancy, infertility. She has been faculty to many conferences, published lots of papers and speakers at all national and international conferences. So Dr. Nalini, I'll stop sharing my screen and you please take over. Dr. Nalini, you are there?
Yeah, ma'am. I'm there. Am I
There she-
audible,
Yeah,
ma'am?
yeah.
Yeah,
yes,
welcome,
yes,
Nalini. You can
yes.
share your screen. Yeah.
Yeah, ma'am. Just a second. Just a second. I think there's some issue with this.
By the time Dr. Nalini is joining, her topic is fasting and its effects. And you know, these days, there are a lot of talks are going on about the fasting, which type, intermittent fasting, alternate day fasting, which fasting is good and what. So I think I'm sure she's going to talk a detail about it and how what is their effect on telomeres and anti-aging.
So after the very interesting talk from Dr. Shilpa about nutrition and its importance and the importance of how we should cook food and what we should be eating, mine is something boring. Anybody doesn't want to fast. We all enjoy food. We all want to feast, but still here I am with the topic with fasting and its effects. And believe me, it is interesting to know that fasting has really good effects on our body. So if we go by definition, it is voluntary abstinence or limitation of calorie ingestion or some type of food, which ultimately leads to the metabolic switch from G to K, where G stands for glucose and K is for ketones, and many changes occur which changes in the activity of signaling pathways. So like I said, it's really not bad. Should we fast? Yes, we should definitely fast. And believe me, it's not at all unhealthy. And definitely it's very advantageous if we wish to lose weight. But yes, it's not very easy. Easy is to eat, but to restrict eating is definitely difficult, and it's no fun either. So let me explain something about the fasting. It's about our cultural etiquette to fast, which needs to be preserved and passed on to our next generation. And also fasting is not at all an obligation, but in a way, I think it explains, it indicates how disciplined you are, how determined you are, and how much strong you are, because it's not easy to fast. So there are various types of fast. If we look into our culture, we have all the religions who fast. The Hindus, they fast and then they feast. There are day-long fasts like Karwa Chauth, like Guru Purnima, monthly fasting. So many people, they follow Ekadashi, Purnima. Then like it is Navratri these days, it is the third day of Navratri and so many people are fasting. But here I would say that these type of fasting, mostly what we do is we feast actually instead of fasting. Like Dr. Shilpa also said, we are mostly, aloo, potato and all those things what we eat during fasting. They are all rich carbohydrate diet. So we think we are fasting, but actually it's maybe very wrong. And then there are Islamic fast. Again, it's first day of Ramzan today, and people fast the whole day. In the evening, they feast. Then there are Jains who do Paryushan, where it lasts for almost 8 to 10 days. Some people, they do Ratri Bhojan Tyag, they don't eat after sunset. And then there are Buddhists who fast in yet another way. With this backdrop knowledge, we need to acknowledge the fact that weight gain is never a constant phenomena, but it's an intermittent one. Who else other than we gynecologists know that how much weight is gained in pregnancy? But we all know that it's almost 11 kgs weight gain in pregnancy, but we don't realize that during menopause, it's associated with an average weight gain of approximately 22.5 kgs, which almost double to that what we increase in pregnancy. And this weight gain is not always steady. It is largely hormonal, not a caloric imbalance. It's a natural cycle of life. Steadiness is always boring, but roller coaster, always interesting. So the natural cycle of life is fast and feast. We don't always do, constant diet. But if you are feasting, then we definitely need to fast. If you keep all the fasting and lose all the fasting, then we definitely are going to get fat. Let us just go into the details of what happens in the fed state and what happens in the fasted state. So our body gets energy from two different places. One is from the food that we eat, and second is from the stored food energy. In the fed state, when we eat food, the insulin level rises. There is no usage of the stored food energy, and insulin inhibits lipolysis and gluconeogenesis. That's the normal physiology. In fasting state, the insulin levels fall. The energy is derived from glycogen, which is stored in the liver, and if it is not that, then from the fat. Now here, like Madam also says, these days we hear so many people on intermittent fasting, so many people are caloric restriction diet, so many people are dieting in one way or the other. In India, we have two class of population. One is the nutrition deficient, the lower class, and another, the IT professional, the young generation who are towards the westernization of the food and eating junk food, and so the obesity is a very common problem, and every second person you find is on some kind of diet. To look at it in a very small, just a few years ago, so most common type of diet that people do is caloric restriction. They restrict the calories, but definitely the length is optional. Then there is an intermittent fasting, which is gaining very high admiration from everyone, and people are using it, and it's very beneficial as this. But intermittent fasting can again be of various types. That is, you can do alternate day fasting. One day you fast, one day you eat normal food. Then it could be time restricted feeding, wherein you either fast for 16 hours, which includes 8-10 hours of sleep as well, and you eat in the window of 8 hours. Then there is periodic fasting, where you fast for 5 days and eat full on 2 days, or vice versa, depending upon how fast you need to lose weight. And long-term fasting is also there. When water-only fasting is also there, we all have seen it in various ways. Then there is fasting mimicking diet. But what actually happens in whatever type of fast you might do? So what happens is the metabolic switch. What is it? It is defined that the fuel switch which occurs when an organism commutes from the eating mode or the feasting mode or the normal eating mode, including generally around 50% carbohydrates in our diet, to the fasting mode. The onset of metabolic switch depends on the liver glycogen content at the beginning of the fast, as well as on the composition of the preceding meal, on your energy consumption and your physical activity. The lipids in the adipocytes, whose levels are increasing when you fast, they are to be partly oxidized in most of the tissues, such as the muscles, the kidneys, the heart, and partly transformed in the liver to ketones. We all uh, know that the ketones are not only the fuels, but because they are also the signaling, they have the signaling effects and they regulate the expression and activity on transcription factors like the peroxisome, proliferative activated receptor C coagulator, sirtuins, polyadenosine diphosphate, ADPs, the ribose polymerase, and ADP ribose as well as the fibroblast growth factors arise in the brain-derived neurotrophic factor in the central nervous system is also known to enhance the brain health. The use of free fatty acids and ketones as energy sources reduces the respiratory exchange ratio. The decreased ATP-AMP ratio will also activate AMP-activated protein kinase as well as create a mild oxidative stress, which will lead to the activation of antioxidant and cytoprotective enzymes. We already have heard about the pro-inflammatory and the anti-inflammatory diets. The G to K switch is the key mechanism. So wherein by increasing the proteins and by reducing the protein utilization is also reflected in the changes in the nitrogen balance. So relying on the ketones for energy during the weight loss has the advantage of promoting the lean mass. Now, what is the lean mass? It is the difference between the total body weight and the body fat weight. Or simply you can put it like everything in the body, the weight of everything except the fat. The fasting mode will be reversed as soon as we move from the fasting stage to the eating phase, triggering the K to G switch, that is from ketones, which are utilized for energy production, to the G switch, that is glucose, which will be utilized. And hence it will increase the insulin levels, the ketones will drop, and cell regeneration in multiple systems occurs with increased mesenchymal and progenitor cells. In this re-feeding phase, the specific effects which take place concomitant to the cell growth and plasticity and leads to functional tissue remodeling and offers a unique opportunity to boost cellular and tissue regeneration. So what are the therapeutic effects? What is the impact on contemporary medicine? So if we go for fasting, if we say it is intermittent fasting, it can also be applied to the long-term fasting, at least in the initial phase. So they lead to weight loss, metabolic reset, switching from G to K, increased insulin sensitivity, reduction in inflammation. We already heard Dr. Shilpa telling about the pro-inflammatory diets, and enhances the immune system. A medically supervised practice of long-term fasting has a long tradition in Europe, especially Germany, and it was considered about 4 to 21 days. There are various studies, and it has been very beneficial in conditions like chronic inflammatory disorders, rheumatoid arthritis, hypertension, diabetes, obesity, etc. There are various phases of long-term fasting. Generally, it was studied on penguins, and it was seen that there are 3 phases, and it also mimics in the human body. The phase 1, where the metabolic switch occurs, is followed by phase 2, wherein the protein sparing effect is seen. It lasts for several days to weeks. And then there is phase 3, which finally starts when fat and protein reserves have reached a particular threshold, forcing the animals to refeed. Therefore, phase 3 is characterized by high catabolic activity as well as adrenergic stimulation and underlines the urgent need to replenish the energy stores. There is various impacts on weight loss as well. There was seen that there was reduction in body weight between 3.2 to plus minus 0.0 kg after 5 and 8.6 plus minus 0.3 after 20 days of fasting. And definitely there was changes in abdominal circumference already explained by my previous speaker as well. There is changes in blood pressure, in diastolic blood pressure, then body mass index also has advantage. Uh, if we see what were the myths that fasting will put you in starvation mode, that fasting will overwhelm with you with the hunger, and you will have to overeat when you resume feeding, that it will deprive you of nutrition, you will lose muscle mass, it can cause hypoglycemia. It's all just crazy. It's not the same. Actually, brain utilizes glucose as well as ketones as energy. And brain can use ketones in prolonged starvation as fuel source and allows conservation of proteins such as skeletal mass. Fat is simply the body's way of storing energy for long-term glucose oblique glycogen is the short-term solution. If we just see over a period of, if suppose there is a human being who lives for 60 years, over a period of 1 year, we consume approximately 1,000 meals. And out of that 60 years, 60,000 meals, if you miss a few meals, you skip few meals, it is not going to be very, hazardous to your body, but it can be very useful. The patients, especially, what is the disadvantage? Especially the patients who are diabetic, it is not very good, especially the unmonitored fast. There is side effect of certain drugs on empty stomach that needs to be taken care of. Then constipation can occur. On a balanced carbohydrate, fat and protein meal, resting metabolic rate, body temperature, and respiratory quotient they increase. The dietary components are utilized to replenish and augment glycogen and fat stored in the body. Excessive carbohydrates in the body are converted into lipids in the liver, and they are stored along excessive lipids as triglycerides in adipose tissue. Amino acids in excess of those which are needed for protein synthesis are preferentially catabolized over glucose and fat for energy production. If obesity and pregnancy we discuss, then we all know that generally it causes fatigue, backache, depression, and surgically patient becomes prone to hernia, to gallstones, and obstetric complications like miscarriages, PIH, type 2 diabetes, IUGR, prolonged labor are also very common in obese individuals. And likewise in newborn, birth trauma, neural tube defects are also seen most commonly in obese individuals. These all can be prevented by daily, restricting our diet to or caloric restriction in one way or the other. And as it was already discussed that wherein obese individuals face early onset of menarche, then PCO, a burning problem in the adolescents and the infertile people, and the basic answer is lifestyle management. Lifestyle management, that is dietary restriction or dietary management. Infertility, endometrial hyperplasia, we all know obesity is again a risk factor. So let it be in PCOS, infertility, vaginitis, if we ask them to modify the lifestyle, we are asking them to cut off their fatty food intake. That is the basic, like madam also said. So you have to, whatever type of fat it might be, kahin se bhi leke aao, chaan se bhi leke aao was her exact words, we have to respect it. So these all can be prevented with simple practice of fasting, and not the type of fasting where we consume only carbohydrates. Earlier, Rishi Munis used to fast because they wanted to save time, but we have to fast because we want to improve our outcome. It is true that we just cannot go on fasting haphazardly. So how it here again it comes how to manage. It is in moderation that we have to manage the fasting. Like I have already explained in my slides, I would just go into a little detail of intermittent fasting, which is gaining very good importance in the over the this generation. Here, the most commonly taken care of is the 8-hour window the patients and the persons can eat, and there is 16-hour window where they can fast. So you can include the 16 hours in the sleep time. So if in the evening you have had your last meal by 6 p.m., like very well explained before sunset, if you take your meal, it's very, very good. So by next morning, 6 a.m., it will be 12 hours. And by 11, it will be 15 hours. So for women, it is said that a fasting of 12 to 14 hours and eating in the rest window is very beneficial, especially to control the weight gain in PCOS, and it also helps to reduce the abdominal circumference. Thank you.
Thank you, Dr. Nalini. Very nicely explained about the fasting. May I have the privilege of asking one thing? Like during this fasting, one can take soups and liquids, or you mean nothing? During this 12-40.
Yeah, this fasting, it is said that we have to, depending upon how much weight you want to lose, you have to restrict diet, and it is very gradual, and it also takes into account that one needs to do some kind of exercise, be it even brisk walking. Maybe you start with 1 or 2 kilometers per day, and then you can go up to 3 kilometers per day. And the food is, again, like it was explained by Dr. Shilpa very well, that is, and Dr. Jayanti also spoke about healthy eating index. Those kind of foods need to be included in this type of fasting, and you have to be gradually reducing. Like I really have examples of the patients of mine who have reduced their weight. We all might have seen in PCOS patients, whatever way they reduce weight, they conceive, and it's very less of the medications which are needed as compared to the lifestyle changes. Intermittent fasting has very good results in a span of 3 months. All the literature and the studies have confirmed this. So
it's also, I mean, if you're not using for weight loss, because it is also said that it improves the telomere lengthening also. So there, yes. What is the, concept, what you can eat in between those 12 hours, liquids or energy drinks or something?
Yes. Not energy drinks, but liquids, especially the plain water, or sometimes the green tea. They are saying that you can drink green tea, and even coconut water and buttermilk. These are the various options that they say can be safely taken during the fasting period. So the best thing is that we can improvise. If suppose there is someone who cannot bunk breakfast, which we all know should never be bunked, then it is always better to eat a little early in the evening, and it is going to make 12 hours, 14 hours by the time you wake up and you start your breakfast. And you can take the second meal in the and skip the lunch, or you can eat during that 8 hours small frequent meals, but the quality of food has to be good.
We'll take just one question because I think time is also short. Dr. Meeta is here. What to take after breaking fast during intermittent fasting and eating cycle?
There is no such specification, but we can eat whatever we like. Suppose there is an individual who wants to lose 10 kg over a period of 3 months, then the person has to go in that kind of manner. Otherwise, you should generally not change the quality of food very much. The quantity needs to be reduced and the timing needs to be reduced, and that takes care of your weight loss.
Somebody wanted you to repeat the intermittent fasting, but I think that is not possible because of the paucity of the time. You can put that. You can put it into the chat box. I think. Yeah, quick word.
Yeah, just a quick word. Generally 16 hours fasting and 8 hours eating window, or you can even do alternate day fasting, or you can even do 5 days in a week you eat the regular food. Yes, restrict your diet a little, and 2 days you fast, which can be the first day or the middle day as per your choice.
Thank you, Dr. Nalini, for a great talk and very enlightening, very informative. The people have already shown so much of interest in it. So let's proceed to the next talk because Dr. Meeta has been waiting. I'll just share it, my screen, and let's. I think Dr. Nalini. Yeah. So Dr. Meeta, we all know, is from Hyderabad, and she is a great orator. She is director, consultant of OBGYN menopause. And I know personally also how much keen interest she has in menopause. And she is very research oriented. Her area of interest, of course, besides menopause, are obstetrics, postmenopausal osteoporosis, PCOS, gynae, ultrasonography. And she's affiliated to many things, founder chair in the Menopause Society Registry. And she has number of awards, editor, Journal of Midlife Health, chair, clinical practice guideline on menopause, chair, clinical practice guideline on postmenopausal osteoporosis, past president, Indian Menopause Society, founder, chair, research committee, IMS, founder, patron, Hyderabad Menopause Society. Dr. Meeta, you are welcome. And I know with seeing your CV, how much interest you have in osteoporosis, and your topic is also related with this only, calcium and vitamin D.
Yeah.
So
Thank
welcome.
you.
Welcome, Dr. Meeta.
Thank you so much, Dr. Kiran, Dr. Vidya, and the entire ICOG team for having this very interesting offbeat session, totally dedicated 3 days on nutrition and different aspects on women's health. I think this is what is really not taught to us in depth during our, undergraduation or the post-graduation. So I think a wonderful job there, and congratulations to the team. So the topic is the calcium, like you all mentioned. So yes, I'm passionate about menopause and passionate about the midlife health, and what we want to do is prevent osteoporosis. And I think you've framed this title also very well, that so I restrict to the role of calcium and vitamin D in osteoporosis. There are other micronutrients and macronutrients which are important for bone health, but we are going to only discuss on calcium and vitamin D in osteoporosis, because this is not how we would want to be. We would want to be like this old lady who's running at the age of 90. And that, so I have no disclosures, but the disclaimer is osteoporosis. When you talk about osteoporosis, only calcium and vitamin D would not suffice. Definitely you would need medication. So that's a disclaimer which goes against the title. So osteoporosis needs medication beyond your calcium and vitamin D or exercise. And it's only the non-pharmacological management to prevent osteoporosis. It spans through the lifespan, which I'm going to discuss a little more in depth. So the agenda would be, first, I would want to explain what is osteoporosis versus osteomalacia, and the role of calcium and vitamin D in bone health, what they stand, what the guidelines talk about. The calcium and vitamin D will end up with that. So the definition of osteoporosis, everybody is aware that it means it's a low bone mass. And then what happens, just like what you're seeing to the picture on the right, severe osteoporosis, the microarchitectural deterioration of the bone tissue. And this definitely would cause bone microfractures, which are not seen initially, but then finally you end up with a fracture which is seen, and it's mainly the spine, the proximal femur, and the forearm. And we have to remember that osteoporosis is a silent, painless disease unless that fracture suddenly happens. So, just like a cardiac event, a myocardial infarction may happen to a person who has never been to the doctor. But then there are so many, but at least there you have a lot of signals which are given by the body before you end up with a myocardial infarction. But unfortunately, for osteoporosis, you don't have any of those signals to tell you that your bones are getting weak. The only thing that's going to tell you the bones are going to get weak is your aging and your postmenopause. So these are the two major risk factors for osteoporosis. But so what is osteomalacia? Because when you're talking about calcium and vitamin D, we have to understand that this is a syndrome which is a result of inadequate bone mineralization. So when you're talking about bone mineralization, it would mean that the osteoid which is laid, the collagen and the osteoid which is laid on the bones, the calcium and the phosphorus, they're all interlinked. So the deficiency of this calcium and phosphorus and vitamin D, which are all interlinked in your endocrinology, leads to poor mineralization. So it's a deficiency disorder. And the deficiency of the calcium, deficiency of phosphorus, deficiency of vitamin D could be due to many reasons and not just because of decreased intake. So there could be other disorders which can lead to these deficiencies of calcium and vitamin D. And then you would say it is osteomalacia. So we know that rickets was very, very commonly seen earlier, but now since the IP and the world over, there is a routine supplementation of vitamin D up to the age of 1.5 years. And once the child is grown up, then they're exposed to the sunlight much more. Only when they are not exposed to the sunlight, or then they are not given the vitamin D supplementation, you still do find rickets in these people. Now, osteomalacia is the same thing that happens in the adults. So osteomalacia can occur in a teenage. So there it can be called rickets or osteomalacia. Whereas osteomalacia is exactly what would happen in rickets. It's the same endocrinological changes which can happen, and it can happen at any age. But the only difference between osteomalacia and your in presentation of osteoporosis, that it is symptomatic. That is, it causes aches and pains, the muscle weakness, so the proximal myopathy, the pain in the upper part around the shoulders and down in the upper arm, and difficult to get up from your seat. So this is called the proximal myopathy, which is very, very common with vitamin D. So one of the hallmarks when the woman complains of not able to get up, apart from the aging, apart from the sarcopenia, not able to get up and upper arms are weak, think about vitamin D deficiency. And gradually when the osteomalacia and osteoporosis with aging interact together, both of them act, and then there is definitely a loss of height, stress-related fractures. But when you see the arrow marks which are put up over there, these are the looser zones, and it is not a complete fracture, unlike what you find in the evident fractures in the osteoporosis. Similarly, in the spine, what you see are the like a fish cod things, that is on top and below. You have hyperdensity and rarefication in the center. Unlike in osteoporosis, where you have the entire thing, which is entire bone, body of the vertebral bone, which is rarefied, and then you have the compression fractures. Whereas here, the presentation is going to be different because the etiology is different. And we have to remember that when we are talking about the prevalence of low bone mass. So by the time a woman is 65 years, 80% of the women are having low bone mass. I'm not talking about osteoporosis, but osteopenia. And this happens about 10 years earlier than a Caucasian. But having said that, though our bone mass is lesser, we are having more osteoporosis. But fortunately, the fracture rate when they have studied in India is lesser than what is there in the Caucasians. So probably because we are more osteomalacia than osteoporosis, and that is the reason why our fracture rates are less. And that's a good news for us because these are all correctable. So just very quickly to go through the relation of calcium, vitamin D, and osteoporosis. Low sunshine exposure, low vitamin D intake, very little in the food that we have gives rise to the low serum 25-hydroxy vitamin D. That is the inactive form, which is formed in the skin. That is converted into 25-hydroxy vitamin D. And from the liver, liver is the storage form of the vitamin D. Then it goes to the kidney, where it gives rise to the 125-hydroxycholecalciferol. And I would want all the students to understand that 125-hydroxycholecalciferol is the active form, which comes as calcitriol in the market, and 25-hydroxy, we have cholecalciferol, which is in the market. Ergocalciferol is the one which is coming from the plants, and it is a cholecalciferol with form of vitamin D, which is commonly used, and that is more potent than the ergocalciferol. And calcitriol should not be prescribed by the gynecologist because we don't deal with the women generally who have a compromised renal function. And moreover, calcitriol is extremely potent compared to the 25 cholecalciferol. So that is a piece of advice that I would give everybody. Please check the prescription that you're giving when you're writing. Calcitriol should not be a part of your prescription, especially for pregnant women, even at menopause, because it's going to rob the calcium out of the bones, make them more osteomalacic later on after 2 or 3 months. So that is why serum calcium have to be closely monitored when you're giving calcitriol. But coming back to the slide, the low vitamin D levels, what happens is then the absorption of the calcium is not there. So one of the prime functions of vitamin D is absorbing calcium from the intestine. So when the low calcium levels, it causes the mineral deficient at the bone that I've explained. It causes muscle weakness. Muscle weakness leads to fall, osteomalacia, low serum calcium increases in PTH. PTH again increases the bone turnover. That means the formation and the resorption increases. So this has causes osteoporosis and osteomalacia together. All of them would lead to any kind of fractures. So this is why your nutrition is equally important compared to the other things. But we have to remember, like I said, osteomalacia is mainly deficiency of the minerals, whereas osteoporosis is multifactorial. So if you're just going to replenish the calcium and vitamin D, if they are replete with that, doesn't mean it's going to reverse your osteoporosis, because there are genetic factors involved, there are endocrine factors involved, and everything is involved over here. But as you see, the peak bone mass that you're going to develop is around 20s and 30s, and later on is what you have to maintain. But it starts off in utero. So utero, the calcium and the vitamin D, what the mother is taking, and then from there on, up to the adolescent age, you have to look after the child till they attain the peak bone mass. And the modifiable factors are the good nutrition, the physical activity, and bone robbers, as we call. There are some of the things which I'm not going to go into the details. So you have to be avoiding all of them. And once you attain this peak bone mass, you have to maintain it, because menopause is inevitable for the woman. Aging is inevitable. But what you can really take care is the physical activity and adequate calcium and vitamin D. So that is where they play a very important role to prevent the osteopenia. So that is where we come in. The gynecologist steps in bone health, because we deal with this women right from the pregnant state. So right from that time, the mother has to be calcium and vitamin D replete, and only then the baby is going to get the right amount of nutrition. And then it goes on to adolescent. We are seeing the adolescent women, when we are seeing them again during pregnancy. And then, of course, you have to look after them at midlife and beyond. So that is where we step in, and I think we have to take interest in this particular field. So why is osteoporosis so prevalent in India? So the slide tells you exactly what I've been talking about. There is a decreased intake of calcium, the ICMR study. There are so many studies in India now which have shown we don't take more than, on an average, 400 milligrams per day, be it urban, be it rural, be it any class that we have. Low vitamin D was found in 80% of the health professionals. A study which I was also involved, 4 centers in India. This was, of course, some time back. We are better informed today. Low protein diet, sedentary lifestyle, early age of menopause. So the first 4 factors are definitely modifiable. So earlier on, Charles had said that it's osteoporosis and fractures are pediatric disease with a geriatric consequence. But I would go one step ahead and say it's an in utero disease with a geriatric consequences. So the good news, we have some evidence from India to state that if there is good nutrition, adequate sun exposure, physical activity, a beautiful study done by Marva, and he saw the impact of lifestyle on BMD. Good nutrition and lifestyle, our bones is comparable to anybody in the West. So why is the calcium deficiency so much in India? Yes, when you see the green color on the top left, the calcium deficiency, a major problem worldwide. You see the green is all in the Eastern countries. That is 75 to 100% of our population are calcium deficient. The lighter green is the one which are replete. This is only 1 to 25% the deficiency in that particular group. See, so the evolved nations have got better calcium compared to the lesser developed nations. Why is it so? Because most important is low consumption of dairy products. Major sources from the cereals and green vegetables. Rice is a very poor source. Diets high in oxalates and phytates, and we have a high salt content. We have very low protein. Lactose intolerance is prevalent, which we are not aware, and most importantly, low vitamin D levels. And why is the low vitamin D levels? Again, there is no food fortification. We know vitamin D, this dietary sources is very, very less. And we have abundant sunshine, but we are either overclothed or because of the pigmentation, because of the pollution, the calcium conversion on the skin is very less. And then there is a calcium deficiency again. So it kind of forms a circle. And as you're aging with estrogen deficiency, things get worse. So according to the Indian Menopause Society guidelines, which are different from the ICMR 2020, and there's a lot to debate on this area, but we have made sure that our postmenopausal women minimum requirement is 800 milligrams. So if our women even take up 800 milligrams, we are happy. Though the ICMR has suggested it was earlier 800 milligrams, now they have jumped to 1200 milligrams. Now, what we personally feel is if you have such a huge jump, the increase in the supplements would go up drastically, which is really not a very ideal situation for the country. So the recommended dietary allowance for the vitamin D is 1,500 to 2,000 IU per day, and the upper toxic limit is beyond 10,000. Tolerable limit is around 4,000. So the slide down, it shows from the NHFS that hardly even in the urban, rural, the urban and rural are, the urban is shown in red bars and the rural is in the blue graphs. But as you see, none of these states, urban or rural, have more than 500 milligrams per day. So that is the condition even today. The World Health Organization recommends 1,300, but most of the Asian countries recommend 800 to 1,000, and there are very good reasons to it. But to make things very simple for all these youngsters who are listening to the talk, we think about soya bean as a good source. Of course, the best source is the milk. One glass of milk will give you about 250 ml of 250 grams of the calcium. Whereas soya bean does give 240, but we have excellent alternatives. We don't have to run for soya bean. We have the rajma, we have the chana dal, and we have methi seeds, and we have ragi, which is 360. It is more than what you have in the soya bean. Then we have the almonds and we have the till seeds. 10 grams, 1 tablespoon, it gives you so much. So every day you can have it as a mouth freshener. And like Shilpa was saying, nuts and till seeds are really, really good. And so many leaves that we have. Drumstick leaves gives you 100 grams, which is so cheap and easily available. So these are what should be promoted at the ground level. Implementation of these is very, very important for each one of you to practice all of this in your clinic, because dietary intake is definitely superior than calcium intake, which I have elaborated over here. And so we say in the guidelines, consume 500 to 600 ml of milk to build that bones, build and support it with lots of vitamin C rich food to increase your calcium absorption. Protein should be 1 gram per kg body weight. Decrease your caffeine intake to less than 200 mg. Salt intake should not be more than one teaspoon per day, not only for your bone health, but for your cardiovascular health. WHO says so many million people are dying because of your salt intake. And of course, the robbers and diseases, the bone robbers should be looked into, the diseases should be taken care. So finally, the question is whether the vitamin D or whether it is the calcium, should it be the diet, should it be the sun, should it be the supplement? So this is what the guideline says. It is preferable to get the vitamin D through sunlight by exposing 20% of your body surface. So that means it is your face, it is your neck, both arms and forearms, without the sunscreen for at least 30 minutes between 10 a.m. to 3 p.m. So 20 to 30 minutes, depending upon the season and the area you're in, whether it's North India, South or East and West. But this was a study done by Dr. Harinaran down South, and he found that 11 a.m. to 2 p.m. is probably the best time. But as you see, this is not practical. Not practical for us to be out there. And when you look at these sources, none of the sources except for cod liver oil gives you 1,360 IU per day for 1 tablespoon of oil. And this is what we used to have as children. You know, every Sunday at least we would have the cod liver oil, and that would really help. And I think it was a practice in most of the houses. But you see the oily fishes, we don't have all of them in India, and it is difficult to get for everybody, and some of them must be vegetarian. So the food sources is less. So we advise for a maintenance dose, which is different. For a deficiency, we would advise 60,000 once a week for 8 weeks. But remember, it's always supplemented with adequate amount of calcium and protein. Only then this vitamin D is going to work for your bone health. Maintenance is from the natural sources. If you're able to go out in the sun and be there for 15 to 20 minutes, at least 5 days in a week, that's good enough. You don't have to take the supplement. Or you need to take 60,000 IU once a month in summer or twice a month in winter in North India. Down south, I think 60,000 once a month is sufficient. Or you can take a daily supplement by an oral spray or a tablet, 2,000 IU, 1,000 to 2,000 IU, and that should be good enough. But always remember, no calcitriol. And so this is a very quick way of calculating how much amount of calcium a woman is consuming, how much of dairy food she is taking, how much of non-dairy food she is taking, and then you know the amount of calcium she takes, exposure to sunlight, time of the day, duration of exposure. 2 questions you ask them, the best way, because calcium we don't know how to measure. Whereas you can measure the 25-hydroxyvitamin D. Serum calcium does not give you the true, does not reflect the calcium deficiency, even the ionized calcium. It just indicates the hemostasis, indicates different things which are different from the calcium deficiency. The indirect measure is the vitamin D and the PTH. So we all know that anything more than 150 is toxic to the body. Between 20 and 30 is deficiency. Up to 40 and 50 is normal. 30 to 50 is what is really necessary to maintain your bone health. And that is also important to maintain, to prevent skeletal fractures. And if you're 30, that means your calcium levels also need to be increased to that level. So this is very important. Anything less than 10 is detrimental for your bone. And when you do the DEXA, and if your levels are less than 10, invariably at any age, it is going to show osteoporosis. That is actually Malaysia. So we have 3 levels of prevention. So calcium deficiency can present in any of the ways that I've been talking about. But when there is excess, it can cause nephrolithiasis and CVD, and that would be a different talk altogether. And the diagnosis, no accurate test exists. So our focus instead has to be on consumption through diet. So remember the dietary chart that I have explained to you, and it's easily available on the net, on the Journal of Midlife Health in this April issue 2022 and even this year. And very important that we maintain the calcium throughout the lifespan. And Kiran, if you're running short of time, you can stop me, because I've given the main gist.
No, you continue. I think only few slides are left, no?
Yeah, so this is all about the vitamin D. I'm not going to talk about the vitamin D and, but then this is the rationale. There were some evidences which I had put in as to why calcium and vitamin D is necessary. Basically it is you're covering the calcium, but that's not enough for the treatment. Once the osteoporosis is there, not osteomalacia, it's not going to reduce the fracture rate if you're just going to supplement the calcium and vitamin D. So all these just telling you that. So target interventions for calcium and vitamin D is when there is an inadequate dietary calcium, at risk of osteoporosis. Whenever a woman is in osteoporosis, elderly people, pregnancy, these are the times where you need your calcium and vitamin D. You don't need to supplement a woman throughout her life all the time. And that is what is happening now, and that should not be done. So food should be the primary source. Vitamin D is necessary for calcium absorption, and various types of calcium, economics, and aging gracefully is very, very important. As you see this, like the Herbartian system, this is cut end of the bone. So the outer ring is the heartwood, which is the oldest, like us. And we support the youngsters which are growing inside us. So thank you so much.
So nice. Yeah.
Thank you. Thank you very much. As I said it earlier, Dr. Meeta is a wonderful orator, and she has so much knowledge that to put in a short 20 minutes package is difficult for her.
Very difficult.
You have done beautifully, covered all the aspects of calcium, practical tips, where the food has to be the great supplement, and about the vitamin D.
Kiran, there are some of the queries.
Yeah, I'm just going to let's go to the queries. Somebody was asking about the pregnancy. Just a minute.
Drumstick leaves. Drumstick leaves can be consumed for the calcium source.
Can they be confused?
200 milligrams per 100 milligrams. And Vidya and Kiran, if you want, I can answer on the chat box. And
Yeah. Please.
Yes. You can do it.
Thank you so much.
They want you to share your presentation. If they can share their email ID directly to you, they please share your presentation. They have liked it, and I think they want that calcium ka slide.
Sure.
And I think Dr. Vidya recorded wala, I was asking the whole recorded.
The whole recorded will be uploaded, but they will edit
later on.
But the slides will not be there. Maybe audio.
Yeah. But many that nutrogenomics, what was that, genomics by the Dr. Sanjay Gupte, that was also quite new thing.
Yeah.
So everybody would like. So
So they
anyway,
are
thanks
practicing.
Dr. Vidya and Dr. Lakshmi and even President Dr.
No, now the post test, no, Jignesh?
Before we'll come to that. Before that, it was a wonderful, I mean, all the speakers have spoken wonderfully. So let's have the post test and then official things.
Meeta, you can answer their queries on chat box, no problem. And we immensely thank you for joining and delivering your ACE talk. And always we love you to talk on this subject, which are also dear to you. So that is really wonderful talk. So thank you very much. And Jignesh, if you are there, please post the post test.
Posted.
Yeah, yes, send the link. Link is there.
Yeah. So all the delegates who have joined, please attempt to the post test. It is already there and only 10 minutes for that.
Dr. Jignesh can start the timer.
Started, ma'am.
Dr. Meeta, can you share your mail ID? If they have any queries, they can directly mail to you. And whether it is possible for you to answer on mail ID. Time up.
Yes, time is up. So now the post-test is finished.
Post-test is finished. Now, Jignesh, can you share?
Yes, ma'am, just a minute.
क्या हुआ जिग्नेश, क्या प्रॉब्लम है?
मैम वो फाइल करप्ट दिखा रही है, 2 मिनट मैम, मैं ओपन कर रहा हूँ.
Whether I can share? I will try to share.
If you are, if anybody of, yeah, anyone of you are
Kiran
having,
is also having. Kiran, can
Yeah.
you see the post-test?
that will be better, Kiran, if you can show and just show the
I
correct.
also have.
Okay, let me. I will have to open it.
I will also open and I'll try.
Ma'am, shall I share, ma'am, now?
Yeah, yeah.
Yeah, if you can, then it is good.
Mine is loading.
Mine is same. So you have to go there and.
Yes. Kiran, just go through.
As we share.
So these are the answers, right answers. Are you able to read or I'll?
No, I have not. Just a minute. Just give me a second. Yes. Okay. So the first question: what dietary modalities work in a diet for PCOS? And next slide, please. The answer is, of course, low calorie, low carb. Slide. Please change the slide, Jignesh. Hello.
Ma'am, your internet connection is not good enough. Vidya, ma'am.
So then, okay. So anyway, it will not move. So what should I do? Should I read it from the mobile? Because I was checked.
Ma'am, slide is moving, right?
No, it is not moving.
Jignesh, we can see only yours. You are sharing the screen, na? Who is sharing?
Ma'am, I was sharing.
So
Again, I will share. Just a minute.
yeah. Kiran, just quickly go through the correct answers.
Yes.
Yeah.
The answer of this is low calorie, low carb diet.
Yeah.
Yes. Next, please. So yes.
Is it moving, ma'am?
Modality?
Yeah,
Yes.
it is
Work
moving.
in a case of lean PCOS. So
Just show the correct
basically
answer.
low carbs. Next, please. So which is the nutrient lacking from diets of Indian women? Well, we all know protein basically is the 0.8 to 1 milligram per kilogram per body weight it should be. Next, please. Hyperhomocystinemia is a result of regulation of folate. So the answer is all of the following. And the next is maternal vitamin D deficiency at dash gestational age is strongly associated with the occurrence of severe PE. The answer is 23 to 28 weeks. This is the reference. Next, please. The serum ferritin levels dash in the hyperhomocysteinemic women compared to normotensive with a positive correlation with both systolic as well as diastolic pregnancy. So the answer is basically significantly, the answer is significantly high. Serum ferritin levels are high. Which of the following statement is true regarding the nutrition in immunocompromised? So the answer is A. That is the limit saturated and monosaturated fat, but consume fat with omega-3 as told just now also. Next, please. Which of the following food items is to be avoided in immunocompromised women? So that is answer is coffee, A. Next, which of the following amino acids are considered essential in pre-surgical nutritional therapy in immunocompromised? And the answer is glycine, A. Next, please. Yes, which of the following is a source of micronutrient zinc? And we all know, I think that this answer must be correct for maximum, spinach. Next, please. For skeletal health, maintain the serum 25 OHD vitamin D concentration between 20 to 40 ml. Is it true or false? So the answer is true. Next. The best index for determination of normal or subnormal vitamin D in the body is ABC, the 25 hydroxy vitamin D, as just A. Then sun exposure. Which of these statement actually we have to? Sun exposure is required for sufficient vitamin D synthesis in skin is basically the answer is A. Sun between 11 a.m. to 2 p.m. for 5 to 30 minutes at least twice a week, providing ultraviolet radiation of wavelength 290 to 320 nanometer. That is the basic requirement. The first measurable consequence of vitamin D toxicity, hypercalciuria, hypercalcemia, which have been observed only at 25 hydroxy D level, and that is above 88 nanogram per ml. That answer is A. So the next is the safe upper limit of vitamin D is 4,000 international units per day. The next, yes, calcidiol is the most useful in patients with, so the basically liver disease. Here it is the most useful. A. Calcium and vitamin D are sufficient to prevent fracture of, the answer is B. Calcium and vitamin, they are not important for fracture, they are for bone maintenance of bone reserve. Question number 18, calcium supplementation in excess of 500 milligram per day should be given in divided doses. True or false? That is true. Next, please. Calcium carbonate provides the highest percentage of calcium. That is true. Next, which calcium salt has the least bioavailability out of these? And that is B. Calcium carbonate has the least bioavailability. Next. Question number 21. What is the recommended allowance of calcium intake in postmenopausal women? And the answer is C, that is 800 to 1500 milligrams. The 22 number question. With low calcium and vitamin D levels, with which hormone is secreted? And the answer is parathyroid hormone, as you just now saw it. C. A pregnant woman with gestational diabetes mellitus should eat foods that are high in, of course, fiber. So that is A. Next. Cutting all fat from your diet will slow the diabetes is false. So which of these nutrients are important as MNT? The answer is D, that is all of them. The postprandial blood sugar is high during the breakfast, which is caused due to the morning cortisol surge, which is called dawn phenomena also. And this can be managed by the B. Answer is, that is splitting the breakfast with low carbohydrate meal. Next is the question number, yes, 27. The timing and frequency of meals are considered important part of the MNT. True. Calories and nutrients to be given should be based on BMI and weeks of pregnancy. That is also true. Question number 29. Which of the following is the nutrient sensitive protein? And that is N-acetyl glucosamine transferase. Yes. And the last question is total parenteral nutrition has a role in, of course, early. The answer is hyperemesis gravidarum. C. I think that is the last question. Yes. Thank you, Jignesh.
Yes. So now it is a time to give the vote of thanks. And I really thank all the delegates who have shown their utmost interest in the nutrition. Please propagate this interest in your respective societies, respective communities, in your practice. If you bring all these points, what you have learned for these 2 days, bring into your practice, that is really useful for your practice as well as for the womanhood. That's what we feel. And I immensely thank Dr. Rishikesh Pai, President FOGSI, Dr. Lakshmi Srikhande, Chairperson ICOG, Dr. Parag Biniwale, Vice Chairperson ICOG, Dr. Madhuri Patel, Secretary General FOGSI, Dr. Ashok Kumar, Secretary ICOG, and series convener Dr. Charmila, and all the speakers of today and yesterday also. Please log in tomorrow. Tomorrow, more interesting topics are there. That is, one is male infertility, female infertility, as well as there is an interesting panel discussion which is based on all the 3 days. So there are many take-home messages tomorrow as well. So please log in from 4 to 7, and that is very mandatory for your certificate also. This certificate, it is not only certificate which is important, because when the lecture series starts, you are more bothered about the certificate than the learning. That's what myself and Lakshmi we were thinking of. So certificate is no doubt important, but to gain the ICOG credit hours, but the learning process also hampers if you put such messages in the chat box. So please read for tomorrow, because you have to attend for the pre-test, no? For that, to read something and come. Dr. Revati, please, you have joined. Really, it is, I'm very thankful. And till now you are there. So thankful. We are very much we express our thanks. And tomorrow again, we are eager to listen to you. And please send this link to all your Madurai OBGYN Society and all Tamil Nadu societies so that they will also all join. So thank you very much. Thank you, Dr. Lakshmi, for staying and giving us opportunity again. And we meet sometime.
Thank you, Dr. Lakshmi, and thank you, Dr. Vidya. It was really, I mean, no one can think is nutrition, so much is there to learn, and really you feel you have never read anything about it so much.